Hello, everyone, and welcome to today's symposium, the third annual Re-envisioning Elder Care Conference. Before we get started, I would like to go over a few items so you know how to participate in today's event. You have joined the presentation using your computer speaker system by default for audio. If you are having any difficulty hearing us, please use an Ethernet connection or move to an area with a stronger Wi-Fi. Shutting down other applications on your device will also open up more bandwidth. You will have the opportunity to submit your questions to today's presenters by typing your questions into the questions pane of your control panel. You may send in your typed questions at any time during the presentation, and we will collect these and address them during the Q&A sessions throughout today's event. For those of you who are joining us in person, you will have a chance to ask your question verbally. Just raise your hand and someone will come to you with a mic so you can ask your question. Today's webinar is being recorded. And now I would like to introduce Dr. Nishira Pandya, Professor and Chair of Nova Southeastern University's Kiran Patel College of Osteopathic Medicine, Department of Geriatrics, and Project Director of the NSU South Florida GWEP. Over to you.
Okay, thank you. Can everybody hear me okay?
Yes.
Okay, thanks so much, Clara. And I want to welcome everybody to our third annual symposium on re-envisioning elder care. So Dr. Paul Katz, who's sitting there, he's the principal investigator of the same GWEP at Florida State University. And I are thrilled to welcome you, all the in-person and the virtual participants. We're really delighted to have you all here. We have an interesting agenda this year, which builds on our theme of re-envisioning elder care. We're going to talk about depression, systemic racism in long-term care, nursing home staffing, caregiver burnout, assuming care for Medicare beneficiaries, new models of advocacy and legislation, and the response to the newly released report from the National Academy of Sciences and Medicine on the national imperative to improve nursing home quality. So I hope that you'll use this opportunity to network, to learn more about each other, and a few housekeeping details before we get started. And cell phone should be on vibrate. The internet access can be obtained through the NSU guest site, okay? And we will have breaks. So we'll have a 15, I think it's in your program, we'll have a 15-minute break. Lunch will be downstairs in the cafeteria and we'll direct you to that. Bathrooms are left of this room. When you exit this room, go to your left by at the end of the hallway on your right. The elevators are on your left. And now it's my great pleasure to introduce my friend and colleague, Dr. Kenneth Johnson, who heads this campus. He's the Associate Executive Dean and Professor of Obstetrics and Gynecology and Public Health at NSU's Kiran Patel College of Osteopathic Medicine. And you are here in our Tampa Bay regional campus, as you know. Thank you so much, Dr. Johnson.
Thank you, Nishira. And welcome, everyone. My job is to pass on a message from Dean Wallace. We are an alternate site, so we added 150 additional medical school seats 3 years ago. Our benefactor, Dr. Kiran C. Patel, was extremely generous in building this 326,000 square foot state-of-the-art spaceship. So we're so excited you're here, and Dean Wallace wanted me to tell you just how grateful we are for the work that you're doing today. I think this is our first, I know this is our first official CME here in the new campus. So you all will always be our first place winners, and I'm from the dean. We hope we can do it with you all here again next year. We're just thrilled about that. I want to recognize some of the incredibly hardworking people that you have here today. I'd like to recognize the South Florida GWEP team. Would you all stand and be recognized? All the team members? Wow. Dr. Paul Katz, please stand and be recognized, sir. You earned it. So our major thrill for what you all are doing and what you've embraced over the years, and I've watched Dr. Pendia, my close friend, impress the nation with her nationally recognized efforts in geriatrics. And certainly we as administrators and deans and faculty, by the way, all of our NSU KPCOM faculty, alumni, and affiliates, raise your hand. So give yourselves a hand. And for all of you out there virtually, thank you for an incredible turnout. What an incredible accomplishment to put on a CME both in person and virtual. I don't have to tell you how much work went into what you're doing today so that we could sit here or be out in Zoomville and enjoy this state-of-the-art activity. But the dean and I and our faculty here today want you to know that because of your work, we routinely integrate geriatrics into our curriculum. And having added another 150 students to our 250, such that we are the largest medical school in the South. No one comes close. We graduate over 400 physicians a year. That number will grow if we have it our way. And isn't that part of what you all are doing? Access to care, diversity in care and for care has never been more, I would say, difficult. So we're solving one of the initial problems by taking what you all are so passionate about, and we're passionate about it. We talk about all of the geriatric issues throughout our first, second, third, fourth year, and then it's vertical into our residency programs. So give yourselves a pat on the back. We couldn't be more excited. We're all in at NSU, as you can see. NSU Health, we're basically unveiling NSU Health. It's a new paradigm for us, and I was thrilled to see this sign. Your place for an age-friendly health system. So thanks for making healthcare friendly for us, all of us. And with that, if you have any needs or questions, Dr. Pendia will give you my email, and I'd love to personally talk to anyone who has a need. Thank you, Nashira.
Thank you.
And thank you all.
Dr. Johnson, that was a really great start and to our sessions. And without ado, I'd like to introduce the first speaker, who is a remote speaker, Dr. Mridul Mazumdar. He is a geriatric and general psychiatrist whose main clinical practice is consultation liaison psychiatry at HCA Florida Hospital in Tallahassee. Dr. Mazumdar is assistant professor at FSU College of Medicine in the Department of Geriatrics, where he oversees and evaluates fourth-year medical and PA students during their geriatrics rotation. He assists in the development of the curriculum for this rotation and provides didactics in geriatrics for third-year medical students and PA students. He also serves as attending faculty for rotating third-year students during their psychiatry clerkship. Dr. Mazumdar's interests include medical student and resident education and treatment of mood disorders. So please welcome Dr. Mazumdar, who will be presenting an update on geriatric depression. And thank you so much for being here.
Thank you so much for the introduction. Is everyone able to hear me?
We can.
Okay, excellent. Okay. Also, thank you to NSU and FSU, the conference organizers and all the hard work that people put in to have this program. And again, thank you so much for the invitation to speak. My topic is going to be maybe a big problem, but a small part compared to some of the my co-presenters who are going to talk about a lot more broad and big picture type of things. But I hope that this will be something to talk a little bit about the state of treatment of a very difficult and often sadly a dangerous and an illness that causes a lot of suffering. Let's see if I can. All right, so disclosures. This is going to be more of a informational resource on depression treatments rather than a diagnostic or a treatment guide. Some of the treatments that I will discuss today are not ones that I have that I actually perform or have expertise in. I do more of the what might be thought of conventional types of treatments of depression, say using various antidepressant medicines and other pharmacologic therapy, but we will be talking about some types of treatments that are more procedural and things that are a little bit, let's say, less conventional, but hopefully in the future will become more conventional. One of the treatments I'll discuss today is not FDA approved. On the other hand, well, that's the ketamine infusion, but there is a form of ketamine that is FDA approved for the treatment of depression. All right. Okay, so our objectives today in this talk would be to review the history of treatments of depression, also look at what might be some of the obstacles in understanding the illness and doing better with our treatment thereof. We'll also talk about some of the newer, or some are maybe not so as new, but some things that maybe we need to consider as things in the treatment of depression, especially for those who are not responding to the often conventional manner. So as an example, we may think of a patient coming in, or someone we might know. Maybe we're a medical provider, or maybe not in some other of our disciplines. But say in a medical clinic, a patient comes in, and as per usual, often there are a lot of screening tools and things that a person may fill out before they even talk to their provider. One is a screening tool for depression, such as PHQ-2, PHQ-9, and often these tools, the more elevated, the higher the score is this would be pointing to often more concern for an illness such as depression and or other concerns such as safety of the patient, suicidality. Let's say this patient comes in and they have an elevated score on a PHQ-9, again, a screening tool for depression. And say, of course, since we're talking about elderly patients, let's say that they're also in the geriatric age range. Often there may be several medical conditions. Let's say they have hypertension, coronary artery disease, dyslipidemia as examples. And one thing to note also is often the more physical discomfort, the more pain symptoms a patient has, the risk of depression also tracks. As the more physical discomforts or other pain symptoms go up, that risk for depression also rises precipitously. Let's say that this hypothetical patient is a person who lives alone, they have poor grooming, they've had some weight loss. They tell you that sleep is tough. They go to sleep, but they keep waking up throughout the night. They have some changes in their level of energy has gone down. And additionally, they are ruminating on past regrets and some of the things that they once used to enjoy, they're not finding it as pleasurable anymore. They're also isolating themselves and not doing much of the things that were part of their typical routine. One of the low-hanging fruit diagnoses we may want to think about is that this patient could be depressed. And in the DSM-5, which is a guide for the diagnosis of these illnesses, a psychiatric illness, we would look for the diagnosis of depression. It would say that the person may have either a depressed mood or anhedonia or both. Anhedonia, again, is lack of pleasure. Depressed mood might be the person coming in and say that they're sad or they're depressed. So we could have one or other of the both. You could, again, theoretically, you could have a person, actually, sometimes it happens, a person who says, I'm not depressed at all. But then if you ask them, well, what are you doing for fun or enjoyment? They may say, well, I don't really enjoy things too much anymore. So they may qualify the anhedonia part of things. Then we would also be looking for 5 out of 9 symptoms over a period of 2 weeks. So if we were to kind of backtrack to this patient, you notice how many symptoms we might count here. They have sleep, their sleep disturbance, energy problems, weight loss. That's 3 symptoms right there. Having some guilty thoughts, it's 4 symptoms right there. Isolating themselves. So there's plenty of symptoms that this theoretical patient is having. We may check for things like thyroid function, blood counts, for looking for anemia. Sometimes there's other causes like mononucleosis and different things like this. Sometimes there could be medical conditions, or sometimes it could be caused by a medication or something else that the patient is taking, maybe substance use and things like this that are causing their depression. But we would look for those different types of things. And the more that we've kind of excluded some of those other causes, we might start thinking that this might be a unipolar major depression. Now, can we confirm that diagnosis with a biomarker or sending a person for brain imaging? Well, not currently in clinical practice, but we would look for the other medical causes. Of course, it's very interesting to also think about maybe, in the future that there may be some of these other helpful markers and things like that. But as of yet, that's not standard clinical practice. So what we really use nowadays is we'll use the DSM-5 criteria for the diagnosis of depression. It is very important to, with the patient that's coming in for depression, to look into their safety. Are there concerns for suicide? Do they have the means? Is that something that they have some intent with? These, of course, may go into other things, looking into crisis and other ways of management. But we're going to, for the sake of this discussion, assume that there is the patient is not having a high risk of imminent suicidality for the purposes of this hypothetical patient in discussion. So let's say that you indeed find that you feel the person has depression, and you start a medication. Let's say you start an antidepressant, and they come back in a few weeks. They're not really feeling too much better. You increase the dose of the antidepressant. Maybe some more time goes by. They continue to be depressed. Let's say you switch the class of medication. Let's say initially people very commonly might start on an SSRI, selective serotonin reuptake inhibitor, medicines such as fluoxetine, paroxetine, citalopram, escitalopram, sertraline, so on and so forth. Very commonly known, say, as Zoloft, Prozac, Lexapro, these types of medication. Then let's say that we switch their medicine to a different class. Maybe we put them on a serotonin norepinephrine reuptake inhibitor, such as Effexor, or I should say venlafaxine, or duloxetine. And then let's say that we've switched their class and they're still not getting better. And hopefully, maybe they're also looking into things like therapy and other modalities of treatment. But let's say they haven't got much better. Okay, now I'm going to kind of go into a little bit more of a historical discussion about some of these medications and, of the conventional treatment of depression. So I've got this rocket here, and we'll talk a little bit about the way usually most problems are solved is we have a deep understanding of the problem, and then we find a way to maybe address it. So like with the germ theory of disease, eventually someone was bright enough to identify, let's say, that a bacterium would invade healthy tissue and cause damage either through direct damage, the immune system causing damage, so on and so forth. And then someone figured out, well, if we could destroy the bacterium, let's say with an antibiotic, then we could address this issue and this problem. So this was, one of the kind of more standard methods of identifying what the problem is and then finding a targeted treatment. Now, in the case of something like depression, I'll give another example. Let's say if a person has a stroke, most medical students and other healthcare providers may be able to understand the pattern of nerves going from the motor cortex controlling, let's say, the left side of the body, going down through the corpus callosum, going into the brainstem, going down into the spinal cord, eventually going out to a motor neuron. They can understand that if there's a problem at any part of those paths, the person may lose motion to the left side of the body, and the whole pattern of the nerves is pretty well understood. Unfortunately, with something like depression, that kind of level of detail and granularity is not there. We know certain brain regions that are affected, but an actual theory of mind and exactly explaining depression, that is not something we're at. Of course, if we were able to do some things like this, we would have great treatments for depression. In fact, we could do things like that, and that type of theory of mind. We could have computers and expert systems that could do exactly what humans do, as well as humans do, but we're not there yet. So why do we have this rocket here? Well, before World War II, there were very few psychiatric medications. These included barbiturates, chloral hydrate, and unfortunately, sometimes the treatments for psychiatric patients were institutionalizing them. There weren't very many medicines. Sometimes some of the physical treatments and things like that were frightening and barbaric. In the late 1940s, one of the treatments we'll reference a little bit later is ECT. This was a treatment modality that was coming on board, but we'll talk a little bit more about more of the traditional medication pharmacologic therapies. So why do I have this rocket on here? Well, in World War II, there were military developments in rocketry. Of course, this is a very dark purpose, and I'm no rocket scientist, but for rocketry, there were, you can think about, in one simple way, we can think about the fuels for rockets as either solid fuels. One of the earliest ones, of course, is something like gunpowder, and then liquid fuels. So solid or liquid fuels for rockets. And the solid fuels often were a little bit easier to work with, easier to store, and unfortunately, often not as powerful as some of the liquid fuels. And so in the World War II, liquid fuels, gained favor. And one of the liquids was liquid oxygen, which was combined with other combustibles to make a functioning rocket. Now, liquid oxygen was incredibly expensive to produce and deal with. So that led to the look for other chemicals that could serve this dark purpose, including a chemical called hydrazine, which is very noxious. It's an irritant. It's a nerve poison. It's cancer causing. It's pretty awful stuff. Now, actually, though, when it's exposed to oxygen, it becomes much less toxic. But anyway, this chemical was a substitute for using the liquid oxygen as part of the reactants in the rocketry. And now the at the end of the World War II, there were these vast stockpiles of hydrazine that were there, and of course, rocketry production fortunately had reduced, and so people were going, well, what do we do with all this hydrazine? And this noxious, carcinogenic, neurotoxin type material it might be easy to think, well, maybe pesticides would be something we could come up with. But some other folks also said, well, maybe we could use it for pharmaceuticals, which didn't seem like a quick logical jump. But of course, sometimes things that are very dangerous, such as elemental sodium or gaseous chlorine, can be very dangerous separately, but combined together they make salt, and they make something that's essential. So anyway, there was a look into using this hydrazine as maybe pharmaceuticals. And so now we talk about tuberculosis. Okay, well, what does tuberculosis have to do with anything? Well, before we have any type of treatment for a communicable infectious disease, what do? Well, we know, of course, just like we did with the coronavirus, we quarantine. So back in the old day, before there was any treatments for tuberculosis, we would put people in TB asylums. Imagine a person is taken away from their family, from their home, from their work, from their loved ones, everything taken and stuck by force into an asylum with a bunch of other people who have a very dangerous illness, who are dying in front of them in a miserable fashion. And you can imagine many of these people became very depressed. Now, one of the hydrazine, which was a component for a developing antibiotic called ipronizid, not isoniazid, which is still used in the treatment of TB, but ipronizid was developed. And this medication was given to the patients in the TB asylums. And whoa, they noticed maybe their TB wasn't getting cured, but they were sleeping better, appetite was better, some mood was better, some people were dancing in these asylums, and they're going, well, what's going on? It's not that they were healed from their TB, but what was actually going on, they found out, was that ipronizid, in addition to having some antibacterial effect or antimycobacterium effect, it was also inhibiting an enzyme called monoamine oxidase. So here's a diagram from Stephen Stahl, who's a famous psychopharmacologist. And here's this flask-shaped object is a neuron. And you could imagine that this neuron might be in close proximity to another neuron, which is not shown. And they communicate with each other by release of neurotransmitters. So let's see here. We have this tryptophan transporter, and tryptophan is a amino acid that we can get from our diet. It is transported into the brain, and then a tryptophan transporter on the neuron itself will bring in tryptophan, and this tryptophan is eventually converted into serotonin. There's a variety of different enzymes. These kind of star-shaped cartoons are enzymes, which are basically in the step of production, or taking the raw material of tryptophan, eventually making it into excuse me, serotonin. And so a couple of different things is that if you stop production of the serotonin, then you may run into an issue where you might see in animal models or things that the animals start acting in a depressed manner. There were some research looking at trying to target this tryptophan hydroxylase, which is one of these enzymes in part of the initial conversion of tryptophan towards serotonin, and those animals became to be more depressed. Now, this other molecule called vesicular monoamine acid transporter, this is a molecule that takes the made production of serotonin, puts it into a package form that can be released for neurotransmitter or neuron to neuron communication and messaging. I'll backtrack a little bit. There is an old antihypertensive, I don't know if it's used too much anymore, but this antihypertensive reserpine that was used, which has effect on vesicular monoamine acid transporter. And what ended up happening is people's blood pressure would come down, but often it would halt the production of norepinephrine, serotonin, dopamine. And many of the patients who are put on this antihypertensive ended up becoming depressed. So these are a couple of things. This monoamine oxidase inhibitor, like the iproniazid that we mentioned, and antihypertensives like reserpine, ended up giving us some idea about some of these monoamine things such as serotonin and dopamine as being implicated in mood. But it's not the full story. The way that most of our modern medicines work, instead of something like, we'll talk a little bit more on that in just a second. But so imagine that this neuron is releasing serotonin, and there's this transporter, serotonin transporter, that is in effect kind of recycling some of the released serotonin. So some of the serotonin will go and connect with another neuron and serve for signaling. But in this case, often what happens is there's a serotonin transporter that's taking some of the released serotonin, not allowing it to communicate a message, but recycling it, pulling it back into the neuron. Then inside of that neuron, there's this enzyme, again, this star-shaped type of cartoon, which is called monoamine oxidase, which breaks down the serotonin. Now, that iproniazid, that antibiotic used in the treatment of TB, that was actually damaging and inactivating this monoamine oxidase. So if you can't break down or can't destroy serotonin, thereby you have more serotonin. And that was part of one of the effects for some of the patients in the TB asylums that was causing a change in their mood. We'll kind of get out of some of these diagrams very shortly here, but for example, that recycling complex, the serotonin transporter, we can target it with medicines like fluoxetine, also known as Prozac. And when Prozac, we take the Prozac for the first day, it comes and basically impairs the serotonin transporter. And so now we can't recycle the serotonin, thereby there's more serotonin that is now available for signaling. And that happens on the very first day. In the very first few hours, the Prozac is impairing this serotonin transporter. Why don't people get better after the very first day? Well, that's because it's not only in the serotonin that's being released or the serotonin amounts that are being released, but it's also about the period of time where this environment is different, and for different receptors to be expressed and other changes that have to occur before sometimes, if we're lucky, we see the important improvements in mood. So it's more than just serotonin. There are other factors. There are the immune responses, and we can look at various types of experiments where they looked at patients with depression versus patients who didn't have depression, who are responding differently if we give them corticosteroids, things such as prednisone, dexamethasone. Okay, and there are significant differences in how the immune system is working in patients who are depressed versus those who are not depressed. Some of these things are C-reactive protein, interferons, these different types of chemical signaling things that are present in the case of patients who are having activated immune systems. Antidepressants and other treatments such as ECT dampen and change and alter some of that immune response. Excuse me. As an example, sometimes when we use interferon for the treatment of hepatitis, and interferon is one of those chemical messengers that's released when we have the flu, these folks get flu-like symptoms and they also end up getting depressed, sometimes as a side effect. So there's not only changes in the immune system, but of course we can think about psychological stressors as in being implicated and causing issues with depression. Sometimes folks are experiencing a stressful life event, but sometimes the patient comes in and say, I don't know why I'm depressed. Life has been going pretty good, but sometimes these stressful events can be starting a chain of events leading to a depression. There's, of course, genes that are involved. There's various genes, such as those that are affecting that serotonin transporter. Remember the reuptake complex that we were talking about? Sometimes people have different polymorphisms of that. So what about some of the syndromes that are seen in elderly? Well, we can think about, some people are familiar with vascular dementia. There's also kind of a vascular depression, if you will. Those patients, it doesn't have to be elderly, but many times it might be an elderly patient, those who have more vasculopathic factors such as coronary artery disease, high hemoglobin A1C, these types of conditions, the more of these factors that a patient has, they become greater, have greater risk for depression. And often this clustering of symptoms, again, remember for depression, you have either depressed mood or anhedonia, 5 out of 9 symptoms, and these symptoms could be very different. But some of the symptom cluster that you might see in the vascular type of depression would be fatigue, difficulty concentrating, and more of the cognitive type of issues in that type of depression. Remember, again, when we talk about the 5 out of 9 symptoms, you could have a patient who's depressed who could have increased appetite. And you could also fairly have another patient with depression who has very, very poor appetite. So you could have a person who might be gaining weight or maintaining weight, and then a person who is losing weight precipitously. You could have a person with depression who's sleeping excessively, or you could have a person who's not sleeping very well. Maybe they have very poor energy, but they're having significant insomnia, versus a person who's wanting to sleep all the time and is not having that much difficulty to sleep all the time. There are various things that we also might want to exclude, make sure that the person who's looking like they're depressed, maybe instead of some of the medical causes, maybe they have another psychiatric cause that might mimic it. They may actually have bipolar disorder, and they're in that depressed phase. And so that might be something that could mimic and throw things off, and they need a different type of treatment regimen than the standard antidepressant pharmacotherapy. So with affective disorders, we may classify them first of all as, what is the affective disorder? We've mentioned bipolar. So if that was the initial bipolar thing, that would be the first part of our naming structure. We might say bipolar disorder. In the case, today we're talking about depression, so we might say major depressive disorder. It could be a single episode if they've only had, they're coming in, this is the first time they've ever had the depression. Or if they've had multiple bouts of depression, then we might call it recurrent. Then we can classify it as mild, moderate, or severe. And then we may also say, are they having any psychotic features associated? So this might be, in the case of major depressive disorder, it might be, it feels like someone's calling my name, or I feel like I always hear something saying, you're worthless, you're not good. It's almost as if I hear this type of voice inside of my head. We again talk about the polarity, the persistence, the severity, and are there any psychotic features that are there? How common is it? About 16% in the US population. About something like 10 to 13% of the US population at any given time is taking an antidepressant. How about male versus females? Well, females are disproportionately affected by depression, but it actually kind of depends on what time of life we're talking about. Prior to puberty, little boys and little girls have equal rates of depression. After puberty, young ladies begin having much more likelihood of depression. And sometimes even some of the birth control and things like this, we could maybe sometimes use it to our advantage. Sometimes the birth control could be causing mood side effects. Sometimes the birth control could be used maybe to be as a way, as an ally to help in the treatment of depressive symptoms. Usually triphasic estrogen progestin combo tends to be the best tolerated for mood. So how much more likely and more do women tend to suffer? About twice the rate that in males. We talked about that. We talked about genetics a little bit, but so again, immune system, genetics, psychological factors, biological predispositions, all these different types of things can come to play in the risk of a patient having depression. So let's talk about how do we look at how good are our treatments for depression. One way of doing this is looking at the concept of an effect size. So if you imagine that this blue curve right here might be a untreated population, let's say with hypertension, okay? And then this red curve might be the treated population who is taking antihypertensive, and the difference between the two is going to be something that we could use with fancy mathematics to come up with a measure called effect size. So in the case of antihypertensives, we might be measuring it on millimeters of mercury of blood pressure. Okay, so this might be systolic blood pressure, and these are untreated patients with hypertension, and these people are now given an antihypertensive, and you can see that their pressures on average are going to be less. In the case of depression, we might be using a tool like a Hamilton Depression Rating Scale or PHQ-9, or maybe we might use something like a Montgomery-Åsberg Depression Rating Scale. Some of these things are used more in clinical studies rather than in common practice, but a PHQ-9 is used very commonly in clinical practice. And we might look at, these are the people who are untreated with depression versus those people who are treated with depression. And you can see it's kind of to the left, and by convention, let's think about going towards the left is a lower number. And remember, in a lot of the scales, the higher number means more severe, more concern for depression. Lower number means less concern for depression. So the effect size, we can scale it between 0 to 1, and the closer that we get to 1, that means that the effect size is greater. That means we have a more robust treatment for whatever we're talking about. In the case of depression, well, also again, with the effect size, if it's less than 0.2, we consider that not much of an effect. Moderate effect is about 0.5, and a major effect is 0.8. And again, as we're going towards 1, that means it's a more effective treatment. We're moving the needle more and more. Okay, so now this is in the general population, not for the elderly. Psychotherapy actually has an amazing effect size of 0.7, but sometimes there is lack of access to the therapy. Sometimes the patient can't afford it, or maybe they have issues of transportation. Nowadays, with a lot of the smartphone and other computer connections, we can get some therapy to the patient. So transportation may not be as much of an issue, but sometimes cost and other issues are there. But that's quite a great effect size. Antidepressants, unfortunately, sadly, have about a 0.3 effect size, which is kind of between moderate effect and no effect. And well, that's not great. Now, so of course, it doesn't mean that there's no effect. It is there. But the other sad thing about, as we get to the old patient, the effect size goes down. Again, just as like little kids are not just tiny adults, older patients, physiology changes, things are different. And unfortunately, this not very great effect size, which is there, it goes down. So what do we do about that? So, we try these various conventional different antidepressants and things like that, and they don't work super great for young people, middle age, this and that. And unfortunately, they work even less so in the older patient. But which treatment for depression has the greatest effect size? It's actually ECT. And we'll talk about that in a little bit. We should also think about, again, not just therapy and medicine, but not just things like ECT, but think about exercise, diet, those different types of things, trying to look at the patient from all different angles to the greatest extent that you can. Now, if we want to characterize, these are also slides I'm taking from Stephen Stahl's material. So imagine that this is a curve where this is more happy and this is more sad. And when we get to 50% reduction of depressive symptoms, we call that response. And if we get up to the 100% reduction of symptoms, we call that remission. And then if we have remission for a long period of time and they don't drop back into depression, then we call that recovery. So this is our big goal that we want to get in our treatment of depression. So if we look at treatments with antidepressants, unfortunately, a lot of the times we see this type of a pattern. You know, the patient comes in, we try antidepressant number one, and if we're lucky, about 33% will get to this remission. And you know, some will get to response, but they still may have the residual symptoms. We may try a second thing, and you can see sometimes that these numbers keep going down and down. Now, these are graphs more for the general population, not specifically for elderly population. And unfortunately, they're not. These aren't so great, but with the older population, it's not it's unfortunately a little bit worse. So what are the other things that we can do besides standard various different antidepressant medications? One of the things that we could look at is what's called repetitive transcranial magnetic stimulation. This is where it's an office-based procedure. There's no anesthesia needed. This is where there is a device that has a changing magnetic field that is placed on the patient. They first find a place where they basically position it and get it to the right area by having it drive your motor cortex and get your thumb to move. And that gives a point of reference to where the areas where we really want it to be having the energy effect of, again, as we changing magnetic field induces voltage changes, we want to eventually target this area called the dorsolateral prefrontal cortex. And so this again is an outpatient done in an office. You have to have this type of device. And often with Medicare, you unfortunately have to go through multiple trials of 2 full trials of antidepressants and then 2 partial trials of antidepressants, all this type of thing. The patient is suffering all the while before we can even try to get to this treatment. But this treatment, after people have maybe failed all these different antidepressants, there's a 40% remission rate. Now, it'd be great if it was 100%, but remember, these people have failed everything else, and now we give them TMS, and 40% are going to do better and get all the way to remission. Now, of course, there's a greater risk for response. There is also now, well, actually, it's been kind of being looked at since 2006, but ketamine infusion. Now, again, this is not FDA approved for the treatment of depression. There is a product called S-ketamine that is an intranasal formulation of ketamine that is FDA approved for the treatment of depression, and the trade name is Spravato for that. Ketamine IV infusion, again, working on the same principle. Again, it's not a fully understood, clearly understood kind of thing. I was drawing you saw some different diagrams and things like this for antidepressant treatment. I don't have a great diagram to show exactly how transcranial magnetic stimulation works. We know it works. We know it has an effect size. We're not absolutely sure exactly all the details of why it works. We know the area of the brain that's going to be important to be causing some energetic and changes to and causing downstream signaling, but I can't explain that directly. Ketamine also, there are some ideas on how it works, but more importantly, I want to say that this might be something to start thinking about more and more. If you look at this, people can sometimes have a rapid improvement in their mood and decrease in suicidality, sometimes as quick as 24 hours. That's much better than telling that patient, well, we're going to start the Prozac and it's going to take 4 to 6 weeks. Look at this. Now, 70% achieved response. So response, again, is 50% reduction in symptoms in 7 days. That is pretty wonderful. Not perfect, but pretty good. Now, of course, ketamine has cost much more expensive than a $7, let's say, prescription for fluoxetine or something like that. $7 a month. This is more expensive. And 75% of responders, again, responder means 50% reduction in symptoms. were in remission by day 28. This is coming from a VA study. Unfortunately, there weren't as many women in that data. And now, how about ECT, electroconvulsive therapy? This is sort of maybe the great grandfather of what TMS is. This is where the person is going under anesthesia. They will have neuromuscular blockade, so they can't move, but they're given a seizure with electrical stimulation, and this is the most robust treatment of depression of them all. Effect size can be 0.9, and it's especially effective in older age. This is a dramatic treatment, and the other really impressive thing about it is that people who are getting ECT often have failed multiple different antidepressants, therapy, hospitalizations, all sorts of different things. They failed all that, and yet such a robust effect size. Again, remember, the closer that that we're going to 1.0 in effect size, the more we're moving the needle. Of course, these things have their cost. ECT is generally very safe. We'd have to exclude it with anybody who's had recent MI. We also have to note that sometimes headaches, some memory loss in and around the time that the person is having the treatment, this could be an issue. And again, exposure to general anesthesia, costs, things like this, but it's a very robust treatment. So kind of in summary, many of the medications, for example, SSRIs, they came to the market starting in the mid-1980s, and this is still we use very commonly. It's not that they don't work whatsoever, but their robustness leaves a lot to be desired, and unfortunately, in the older population, their performance is worse than it is in the general population. One thing is that, again, we should consider looking into patients who are suffering with depression and are not responding to the therapy. Of course, we also therapy has a phenomenal effect size of 0.71, but we need to try to get our patients to maybe for us to also think about, let's try to look at some of these other modalities because unfortunately people suffer greatly from depression. Unfortunately, there are high rates of suicide. Most patients who are committing suicide have depression. 45,000 plus or so people in the U.S. every year. So these are some things that I think that we should consider. So anyway, I don't know if there's much time for questions, but I hope I look forward to the other presenters. And again, thank you so much for allowing me to speak in front of the audience today.
Great, thank you so much, Dr. Mazumder. We're going to begin answering some of the questions that were submitted during today's presentation. And just as a reminder, you can still submit questions through the questions pane in your attendee control panel. Or if you are in the live classroom, please go ahead and raise your hand. Your first question is, and this came in, I think when you were on slide number 21, is this something that has replaced electric shock, and is that still being done?
Yes, so this is the same thing. In the past, sometimes there were portrayals, and it was done in a less humane manner. If anyone saw the One Flew Over the Cuckoo's Nest or things like this, but it is the same thing. Electroconvulsive therapy is the same thing. It is now done under anesthesia. The person is in neuromuscular blockade. There is a anesthesiologist, psychiatrist there, nursing staff there. It's done under a very highly monitored condition, and a electric impulse is given to the person who is under anesthesia, so they wouldn't feel anything, and they're also not. They wouldn't be having the motoric movements. So they're one and the same.
Okay, thank you so much. Dr. Pandey, do we have a question in the room to ask?
We have a question in the room.
Hello, doctor. My name is Michael Canalupo. I'm representing ALMA, which is UCLA Arts and Healing's initiative to address loneliness in movement, art, and therapy in elder care facilities. Just as an aside, I'm an advocate for psychedelics in the treatment of mental health care. So mentioning ketamine, I'm very happy to see that. And in the future, I hope that we'll be seeing some of the studies from Johns Hopkins on psilocybin and beyond for the treatment. But a lot of my work goes into kind of understanding actual quality of life, root causes, systemic sort of points of care in elder care facilities. We're doing it there in Southern California, but I'm wondering what sort of work is being done to sort of try to understand what may be happening more than just on medicinal level, what may be causes, what may be concerns in elder care facilities here in Florida, and how we may be addressing that.
It's a pretty broad question. I don't know if I have a great answer for you on this. My approach, and generally what I'm doing, is more in regards to the treatment with different pharmaceuticals, and more kind of that part of is a little bit more of my niche. I want to just say that again, the more that people can look into other things such as creating a better environment, non-pharmacological approaches, exercise, diet, involving folks, addressing loneliness. I'm a big advocate for all of those. I think this is as I'm pointing out in the discussion, it's a very complex problem. And there's a roots in multiple different systems. A person who's depressed is not just sad; it's affecting multiple body systems, immune system, diet, sleep, cognition, all these different kind of things. And there are many people who are doing some excellent research. I'm not. I do a very little bit of research, but mainly I'm more of a person that's standing on the shoulders of the giants who do create these different type of things, and I try to use those in the patients that I
Okay, great. Thank you. Maybe we have time for one more question. Do we have any more questions in the room?
Thank you, Dr. Mazumdar. I have a question, if anybody else, in case anybody else doesn't. We know that people with diabetes have probably twice as much depression as in people without diabetes, in practically all ages. Is this a vascular process? Is this a vascular depression, or are there other factors causing more depression in people with diabetes?
So one of the things is that any type of chronic general medical condition is putting a person at risk. These, again, multiple different hypothetical type of causes could be there. The variance in the blood sugar levels, of course, our brain is a 3-pound organ that's taking a vast portion of the resources given for the tiny size and amount. But any of these factors that are, the hyperglycemia, of course, can be very damaging to our peripheral nerves, but it can also be very damaging to our central nervous system. Any type of chronic illness can also cause inflammatory states, and these things are also causing, again, a lot of issue. But one of the things is, unfortunately, a full theory of exactly why depression is happening. If like I said, if a person has a stroke, we might be able to very easily diagram and understand the tracks that explain why a person can't move the left side of their body. But exactly why someone has depression We know some of the implicated brain areas and can use functional imaging and things like that, but a real true theory of depression and a true understanding of that with involvement of psychological, chronic medical illnesses, genetic factors, all these different things is not there. At least I don't have that. So I think that makes it these questions are not super easy to.
Thank you so much. I think we need to move on to our next session. So many thanks for your presentation, Dr. Mazumdar. It's very interesting. And now I'd like to present our next speaker, Dr. Tatiana Shippey, and she's here in person. We're thrilled to have her here. She's a social gerontologist with a dual title PhD in sociology and gerontology. She's a tenured associate professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health and associate director for research at the Center for Healthy Aging and Innovation. She spent 2 years, this impressed me the most. She spent 2 years living in a long-term care facility to better understand factors that impact quality of life for older adults in long-term care settings. Her work aims to eliminate racial and ethnic disparities in access to and use of long-term care services and supports, and improve quality of life for older adults. She was recognized at the University of Minnesota President's Community Engaged Scholar for Public Health in 2017 and has a broad network of community collaborators and partners, including the state chapter of Minnesota Diverse Elders Coalition. She has led and continues to lead multi-million-dollar projects to address equity and quality in long-term care, funded by AHRQ, the NIH, and the Minnesota Department of Human Services. She's also served on the advisory board of the Gerontological Society and its inaugural Diversity and Justice Committee. So please come to the podium, Dr. Shippey, and welcome.
Thank you so much for that introduction. It is a pleasure to be here. Can everybody hear me okay in the room? Yes. Hopefully everybody can hear me okay online as well. Well, again, great to be here in person, and I really appreciate the invitation and the willingness to engage on this often very challenging yet incredibly important and pervasive topic, the issue of addressing systemic racism in long-term care. Make sure I can navigate my slides here. Okay. Okay. Well, I would be remiss if I did not first acknowledge my team and funding for this work. So the results that I will be sharing with you today have been funded by the National Institute on Minority Health Disparities and National Institute on Aging. They were actually part of an R01 that just completed in April of this year. So I'm very happy to share the results with you and hopefully look for how we can all collaborate and push for action and change. And I also want to acknowledge my wonderful team, because this work absolutely must be team-based and collaborative. And you see some of my research assistants and project manager here. So what I'm hoping to accomplish in my 40 minutes or so with you here today is to get at 3 objectives. And my goal is to leave enough time for questions, because I want to hear from you and get engagement with folks who are joining virtually and here in person. First, I want to talk about how systemic racism impacts quality outcomes in long-term care. Second, I would like to share some of the research from my own team and my lab that I direct, which is called Equals, Equity and Quality in Long-Term Services and Supports. And I was so pleased to hear that there's somebody here in the audience interested in quality of life. So we will absolutely talk about quality of life. And then I'd like to talk about solutions. Where do we go from here? What's the role of policy? And really, all of you as providers, I know there are so many providers here, medical directors and others in addressing these disparities. So first, I'd like to start just by defining racism. And I like to use the definition by Dr. Kamara Phyllis-Jones, which states that racism is a system of structuring opportunity and assigning value that's based on race that unfairly disadvantages some individuals and communities unfairly advantages other individuals and communities, and in the end, saps the strength of the whole society through the waste of human resources. Racism, systemic racism in particular, has been declared a public health issue. And it is so because its consequences, whether intentional or unintentional, bring great harm. And what I would like to focus on today is I would like to show you through empirical evidence and my own work and the work of others in how systemic racism has been manifesting itself to bring about these disparate outcomes in long-term care that many of us talk about but don't get at the root causes. I am very pleased to see that, and we'll be having a panel on this at the conference today, that the recent report by the National Academies of Science, Engineering, and Medicine has acknowledged the need to find solutions to systemic racism in long-term care. And I'm very pleased to have co-authored work. I put examples of the two recent papers that I've co-authored with a number of my team members on evidence for action. How do we acknowledge, because if we don't acknowledge that the issue exists, we won't be able to do anything about it. Acknowledge that there is a problem. 2, develop solutions. And 3, move to implement them so we can address equity for all through addressing existing racism in long-term care. How is it, you might ask, that we see racism manifesting itself in long-term care? Well, one of the very, I would say, most direct and very, I would say, apparent ways that we see it happening is the racial segregation of long-term care. In fact, long-term care is the most racially segregated aspect of healthcare. And here we shared that I spent 2 years living in a long-term care facility, and my work is very much community engaged and uses mixed methods. So while I do big data analysis, claims data, MDS, I also spend a lot of time in long-term care facilities. And for this work I'll be sharing with you today, we did ethnographic observations where my team spent 3 to 4 months, at least on average, observing and understanding care in facilities that have many individuals from communities of color. And I will tell you that in some of these examples, I was shocked because it seems as though these facilities are in a third world country, when I can also compare them to predominantly white facilities, the place where I lived for 2 years in a continuing care retirement community. And the differences are just very shocking. We know there is a lot of research that demonstrates poor quality, worse quality of care for people who are Black, Indigenous, and persons of color. So for the purposes of my presentation, I will use this acronym BIPOC, Black, Indigenous, and persons of color. We also know, and there is more evidence coming on this, that there is decreased availability of higher quality community options for people from communities of color. So when they're in nursing homes, they have worse quality of care outcomes, but also they can't get access to better quality community options, which many of them would prefer. And of course, much of this has really got the attention of the general public was because of COVID, right? Up until COVID, many of us who have been doing this work have sort of been publishing these papers, doing this work, but it hasn't really risen to the level of attention that it is now. And I'm so happy we're talking about this here today with all of you, because all of a sudden many folks said, wow, we didn't realize that nursing home care really needed improvement in the US. And wow, look at the high rates of COVID death in nursing homes. And look who is dying at much higher rates and facilities that have higher rates of COVID infections. Oh, it's primarily facilities that have higher proportions of Black people. So what I would like to argue here, I think there's supposed to be a poll, I believe. So I don't know if there is somebody who can tell me. I know we had poll question. Yes. All right. So could you, I don't know how you could do this for those of you in person, but virtually, have you seen racism manifesting within long-term care settings? Doesn't have to be just nursing home, could be assisted livings, home care, home and community-based services. Yes, no, or maybe an unsure. And then there'll be a second question. Maybe we could look at the results of the poll.
The results are coming in. We'll just give it maybe 20 seconds here or so just to get a few more results, and then I'll share them, and then we can move on to the next poll.
We need some clickers for those of us in person. Okay.
Okay, I'm going to close the poll and I'll go ahead and share the results there for you.
Okay, well, I am not surprised to see the 73% of you answering yes, but I also want to say thank you for being honest, because I have presented some of this work before, and I think sometimes there is reluctance to acknowledge what it is that we see in front of us. So, and for those of you who had maybe an unsure no, that's okay too. And obviously there are great differences, big differences, state differences, differences in where the facilities are located. But it's important to know that most of you are seeing, yes, we see this as a problem. Let's go to the second poll. Oh, maybe we'll skip the second poll question. Yes, it is there. If yes, what are some ways that you have seen it manifesting? Racial segregation of long-term care, disparity in quality of care, quality of life, and maybe some other mechanism, because certainly there are a variety in ways through which systemic racism plays out.
All of the above.
All of the above are the answers I'm getting at. All right, I don't know when you'll close the poll, Tiffany.
We'll just give it a couple more seconds here just to allow a few more people to vote. Okay, I'm going to go ahead and close it now and share the results with you. Here you go.
Okay, so the results are most of those who said yes, they saw that there is a presence of racism in long-term care. 36% said that they saw it through disparity in quality of care. 29% other, I'd love to get more on this. Hopefully we have time in Q&A. 21% through racial segregation of long-term care, and 14% through disparity in quality of life. And here in the audience, folks said all of them. And I think that's what really the evidence shows. It plays out through all of the above and more. And it is so important for us to address all of these areas. Thank you for your participation. So what I'd like to do maybe the next 10 minutes or so is to share the results from my work, which specifically focuses on quality of life. As was shared earlier, I spent 2 years living in a long-term care facility in early 2000s when I was getting my dual doctorate in gerontology and sociology. And it was from that experience that I became a passionate believer and have dedicated my career to focus how improving and prioritizing quality of life for long-term care residents. When I lived in this facility, residents told me that even though they were in a long-term care facility because they needed medical care and they very much valued what all of you as medical providers are doing, in the end of the day, they wanted to have a reason to continue living. As one of the nursing home residents told me, if I have nothing else to look forward to tomorrow, just shoot me today. And so how is it that we create purpose and meaning for people who are receiving care in some sort of a long-term care facility, assisted living, nursing homes, senior independent living, and or people in the community? But my work will focus on residential long-term care. And that is the part of my presentation here today. When it comes to focusing on, oops, my slides are not moving now. When it comes to focusing on quality of life, I have done a lot of work in Minnesota, which is one of the few states in the nation that really, I would say, does a very good job in prioritizing and collecting quality of life measures. When I first started working with Minnesota Department of Human Services and doing this analysis, I said, well, I really want to understand, are there differences in these scores by race, ethnicity? And the director of the nursing facility unit at that time, who is a wonderful man, and we've collaborated for many years, but he said, no, you're not going to find anything because A, Minnesota is so white, and B, really, we don't think there would be differences. And I think his sentiment is really reflected by much of the social science literature up until recently, which sort of has pushed this narrative that people from communities of color, BIPOC individuals, they don't want to use institutional long-term care, which is true. They receive care by family members. Many of them have intergenerational family situations and living arrangements and will receive care in a community. All of that is true, but that also has been changing. And I feel that this big demographic trend in terms of who is receiving care in our nursing homes in particular really hasn't received the national attention that it should. So first, our population is becoming more racially, ethnically diverse. And we also know that the proportion of BIPOC older adults has increased in nursing homes, so much so that it will surpass the proportion of white adults by 2030. And what we see, some of us have called this the white flight out of nursing homes. We see, and this is an older paper from 98 to 2008. My colleague, Dr. Jasmine Travers, just published a new paper that has same trends. And that shows that there has been an increase of about 55% in Hispanic older adults who use nursing homes. We see an increase of about 54% of Asian older adults, an increase of 10% of African American older adults, and note this, a decrease of 10% for white older adults. And that number has only increased. So proportionally, BIPOC older adults will surpass the proportion of white adults in nursing homes. Why? Well, there are many factors. We think about how systemic racism plays here. Many white people, if they have more resources, prefer assisted living or other care settings. And for many, in particular, Black older adults, as I have seen from my work, nursing home becomes sort of an only place where they can receive care based on Medicaid availability, even though often their care needs are such that maybe they should be receiving care in a different setting. Despite this change in demographics, we know very little about quality of life for BIPOC older adults in nursing homes. And that's what my work has tried to do. We do know, as I shared before, and there's quite a lot of work, a large body of literature on quality of care, that A, nursing homes are highly racially segregated. B, BIPOC older adults are more likely to be placed in lower quality nursing homes through a variety of mechanisms. I've seen how it happens in practice. A hospital has a partnership with certain nursing homes. They know which facilities will take residents with certain characteristics. And so there is this sorting of residents, if you may, into poorer quality of care facilities that have access to fewer resources. And of course, as we know, there is racial and socioeconomic segregation of nursing homes. So what I wanted to share with you are results from my analyses in Minnesota. I'm only showing you data from Minnesota because we currently don't have a national database that has quality of life for nursing home residents that is using a validated person-reported measure. Minnesota does have it, and I'm very pleased to serve on the newly formed Moving Forward Nursing Home Quality Coalition that builds on the NASIM report, because the NASIM report called for national person-reported measures of quality. So hopefully we will have these measures in the future in the nation. But what I will be sharing with you are results from Minnesota. I'm showing data today from 2010 to 2015. I've conducted analyses through 2018 now. The results are very similar. And what you see here is 3 data sources. First, a Minnesota legislature invested starting in 2005 in collection of in-person interviews in all Medicaid, Medicare certified nursing homes where residents are asked in person questions about their quality of life. They conduct about 13,000 in-person interviews every year, and they ensure that the random sample of residents that's pooled has enough of a margin of error that results can be reported on a facility level and then are posted on a report card. This has been great because now the state has also invested in quality improvement measures, pay for performance to target those measures. These rate of about 85% and have pretty much all of our facilities in the state of Minnesota. And then what I have done, I have linked these in-person resident interviews with their clinical data from the minimum data set. And I also linked it with the facility characteristics that we get from the Medicaid cost reports. So in the end, we have a data set that has resident quality of life interviews, resident clinical characteristics from MDS, and characteristics of facilities where they receive care. And so I'll share some broad results with you and happy to answer more questions in detail. First, what we found is that residents who are Black, Indigenous, and from communities of color have different care needs in nursing homes when compared to white residents. On average, we find that BIPOC residents in Minnesota are up to 20 years younger. That's a big difference than an average white resident. We find that they're much more likely to be male, while a typical white resident is more likely to be female. They have a longer length of stay, so they're more likely to convert to be a long stay resident. They have fewer impairments in activities of daily living, less likely to have cognitive impairment, but more likely to have diagnoses of severe mental illness and behavioral symptoms, which we also know could be manifestations of structural racism. My colleague at the University of Minnesota, Dr. Shekinah Fesher-Walters, recently published a paper which showed that Black residents are much more likely to have diagnoses of schizophrenia compared to white residents who have had similar characteristics. We also know that BIPOC residents live in different facilities. In Minnesota, they're much more likely to be in urban facilities rather than rural facilities. They are more likely to be in for-profit versus not-for-profit. This is true nationally, by the way. BIPOC residents more likely to receive care in urban, large, for-profit facilities, proportion of Medicaid per resident day, facilities that have lower rates of staff retention or higher rates of staff turnover, and facilities that on average have fewer staff hours per resident day. And this is true across different specialties. Oops. So here are some of the key findings from my work on quality of life. And I want to put this in context again. My results are from Minnesota. I do believe that they're transferable and applicable to other settings. And you should know a few things about Minnesota if you don't. Minnesota is one of the 2 states in the nation that has Medicaid rate equalization rates in our nursing homes. What that is, our legislature passed this about a decade ago, is that our Medicaid rates are set at the rate of private pay for shared rooms, but not private rooms, meaning that likely the disparity in Medicaid pay in Minnesota would be much smaller than in states that don't have rate equalization. So I would argue that from the onset, the disparity we find in Minnesota might be more conservative than it would be in other states that don't have Medicaid rate equalization. But based on the data in Minnesota, we find that Black and Indigenous residents report lowest quality of life scores compared to residents from other racial ethnic groups. These differences are statistically significant and meaningful. And what I don't have enough time to describe is how we measure quality of life. But broadly, quality of life is a multidimensional measure of well-being, and it has different domains, some that you would expect, like food satisfaction, activity satisfaction, relationships with staff, like do staff know me as a person? Do they treat me well? Mood, we talked about mood in the earlier part of the presentation today. So across these domains, we find that the domains or areas with the lowest scores include food satisfaction. This one is a huge area for our residents from diverse racial ethnic communities. Meaningful activities, much lower scores, and attention from staff. And this is where, again, do staff treat you as a person? Do they know you? Do they know your interests and hobbies? And so this is on individual level, but I'm trained as a sociologist, so I also think about systems and structures. And so the other way to think about it is, what about a proportion of residents from communities of color in a facility relative to proportion of white residents? And we find that white residents who live in primarily white facilities report the highest quality of life scores, while Black residents who live in primarily Black facilities report the lowest scores. What you see here in all these lines, and I don't have a clicker actually here with me, but what you see are trends in quality of life over 5 years. As I said, the analysis through 2018 showed the gap is actually widening. And what you see, that solid blue line on top, are the scores for white residents who live in primarily white facilities. You see that our white residents in Minnesota are actually pretty well satisfied. About 80% of them report that their satisfaction with their overall quality of life score. So all of the domains added together. First bar is the unadjusted. That's just their quality of life scores. Second, because I have all of the MDS data, I adjust for these clinical characteristics, which I already told you are different, right? So I adjust for age differences, gender, ADLs, cognitive impairment, and a number of other diagnoses. Even when I adjust for those characteristics, you see that the solid blue line does not change very much. And then the third bar adds the facility characteristics. So notice for white residents, just slightly lower difference. But across all of them, I would say that the dotted red diamond line are for the BIPOC residents who live in primarily BIPOC facilities. You notice that even when you adjust for resident and facility characteristics, look at the difference between the solid blue line and the dotted red line, and that is the gap that we are observing in quality of life. That's the interaction of one's individual race, ethnicity, but the site of where they're receiving care as well. And this last slide on the quantitative results, and sorry, this got moved a little bit. What it's using here, because we can use statistics in a variety of ways. I'm using methodology called Oaxaca decomposition. It's an econometrics approach, which allows to estimate what proportion of variance in a particular outcome is due to which characteristic. So I'll give you an example here to make this a little bit more understandable. So look at I noted that attention from staff, that's the first one, food enjoyment, engagement in activities, and positive mood are examples of some domains where we identify racial disparities between BIPOC residents and white residents. What I'm doing here now is I am using this econometrics approach to be able to assign how much of that difference is due to resident characteristics, how much of it is due to facility, how much of it is maybe unexplained, and that's pointing to the need to address other factors, unobserved factors that systemic racism is bringing into these outcomes. So look at, for example, at food enjoyment, because this one is so prevalent. When you look at this bar for food enjoyment, you see that there is a 12-point difference. That's the number on top. That's the difference between white residents and BIPOC residents. And I am aggregating everybody into this BIPOC category, knowing, just putting a disclaimer, that there is a big problem in doing so. But also in Minnesota, we don't have that many residents of color. So I would actually say, if you know statistics, the fact that we are finding these differences to be statistically significant when most of our residents are white does show to the size of the effect of this difference. So look at this food enjoyment, 12-point difference. You will notice that 1.3 of those points is due to resident characteristics. Okay, you know, residents' clinical diagnoses are going to influence food enjoyment. All right. The gray one, 1.3, another similar one, is due to them being in a high proportion BIPOC facility, which we know is a proxy for under-resourced, high proportion Medicaid, and a number of other factors. Then this blue one, 4.5, quite a good, I guess, what, a quarter of that difference, a third of that difference is due to other facility characteristics. Is it a rural versus metro facility? What about staffing ratios? So facility characteristics matter, and we'll talk about those in other sessions today. But notice, the red, the dark red or maroon bar is the unexplained disparity. And you all, I have clinical characteristics, I have the quality of life scores, I have facility characteristics. To me, this is an example of how systemic racism manifests itself through these outcomes. And what are these unexplained characteristics? I'll show them to you through some of my qualitative data, because, you know, our quantitative, our big data sets are good. We need them, but they obviously don't capture everything. And so the question that I'm asking next is, what are some mechanisms that shape quality of life for residents in these high proportion BIPOC facilities in Minnesota? To do that, as I started telling you, my team carried out ethnographies of 6 high proportion BIPOC facilities. We did at least 3 months, sometimes more, of participant observation in each facility, which ended up to being over 600 hours of participant observation. And the way we do this, I had my project manager, a wonderful man named Moses Wisewa, who is a Black man, very involved in the community, basically stationed in each facility for at least 3 months as a free volunteer. And let me tell you, each of these facilities really, really needed his help. They were so under-resourced, so he would deliver meals to residents. He would run activities. He would go get clothes that, you know, many other activity coordinators were getting, and really assist. You know, he got to know all the nurses. And so Moses was sort of our main, he is there every day for 3 months, but also other members of the team, including myself, all went through volunteer training for each facility and would come in to ensure we have sort of inter-observer reliability and observe different parts of care. Evenings, mornings, come for activities, come for meals, come for, you know, family meetings. In addition to those observations, we did interviews with 96 residents and interviews with 61 staff. We also did focus groups in each of the communities where these facilities were located. So for example, one facility was a high proportion Hmong facility. Minnesota has the highest proportion of Hmong and Karen refugees in the nation. So that was one of our facilities. Most of the other facilities were high proportion Black. One facility was split in being high proportion Indigenous and Black residents. in thinking about this, I know there is a lot of text on the screen, but I think it's really helpful to think about what are the frameworks and models that are guiding our questions. And so here, I think it's very helpful to think about the framework developed by the National Institute of Minority Health Disparities in how is it that we think about levels of influence on the individual, interpersonal, community, and societal levels that race and racism operate to result in different outcomes. So I will talk about three of these levels. I will talk about the individual level of influence, interpersonal and organizational, and community level of influence. On the individual level of influence, we certainly saw how racism, sort of baked in a system, influenced resident relationships. One of those ways was the segregation based on residents' race and ethnicity. So in one facility, and this facility was sort of high proportion Black, Indigenous, and it had people from other communities of color. It was interesting because one floor, the main floor, was all white administrative, business staff, administrator of the facility. Second floor was all Black, and then the third floor was all Asian. I mean, it was like absolutely directly split by race, ethnicity. You typically don't see that much of a direct segregation, but residents certainly talk about segregation by race, ethnicity. They talked about how one, and this was actually an interesting finding for me because I don't see it in the MDS, how many people in these facilities did not speak English or for whom English was not their first language. And you know, MDS obviously is used for care planning, so that's not a field that people will often indicate. But we found many individuals, you know, people who are saying, you know, okay, I don't understand English. And so we had interpreters. We did interviews also in Vietnamese and Hmong, I should note, with members of these communities. We also heard quite a lot about tensions among BIPOC and white residents, use of racial slurs. I have observed use of racial slurs, but I should also say that the greatest use of racial slurs that seemed to be very unapologetic was not to residents, but to staff. And that to me was shocking. And that's a whole other area that must get more attention. But and then instances of, you know, aggression and tension, people saying, oh, you know, I'm an African immigrant, and so, you know, they don't care about, you know, culture. There were instances of, you know, people who are Muslim and their food, you know, they know that they will not eat certain foods, and yet those foods are served, and sort of disregard for people's culture, race, ethnicity, and really their values. The second way in which this operates is through interpersonal and organizational characteristics. And this gets at care that residents receive from staff, opportunities for meaningful engagement, and opportunities to have culturally appropriate meals and food, which again are so important and should not be underrated, because I will tell you that from my 2 years, just 2 years of living there, if you eat spinach souffle every evening, you do get very tired of it, and you must have food that is culturally appropriate. So care from staff, you know, here are some quotes from residents. You know, what the residents, this Hmong resident said, yeah, they try to treat us good. But to say it, the people who can speak English, they have to wait for the last minute, and they take their people first. And this is just an example. We heard this a lot. People who are minoritized, people who are BIPOC, but if they also don't speak English very well, that is an especially vulnerable group. The translation systems don't work as they should, and often they are left waiting, and we've observed it happening, and maybe not getting care at all. And then it's interesting because we've heard this from both ways, residents talking about how staff race ethnicity, if it was concordant with residents' race ethnicity, there was a perception that maybe there was better care that was delivered to those residents. Activities was a huge area, an area that really must get more attention, especially for residents with dementia. And I'll read you this quote from this African American resident, a man, because remember, more BIPOC residents were more likely to be men, who said, there is nothing to do here. Play cards, back. Play cards, back. I wanted them to try to juice up the schedule, get a focus group together so we could have to choose. Because you got younger people here, and they don't want to just sit and play bingo with half of the folks who don't even know what's going on. And this is a big reality. When you have people who are younger, who are there because they can't get housing, supportive housing in the community for mental health and other issues, they are stuck. And this was very sad to watch. And there was also, you know, other activities going on, alcohol and use of other substances that should not be happening in a facility. And what I saw in all of these high proportion BIPOC facilities, all of the activity staff were white women, very well-meaning white women, but also white women who received no training on how to provide activity engagement that's meaningful to their African American residents. This was especially a huge problem on dementia memory care units. I don't have time to talk about it, but my work also specifically focused on memory care units in a different related study. And there was no programming. We saw African American residents sitting in front of TVs. We observed it day by day with no engagement. The music, the activities that were done were not culturally sensitive or meaningful for them. And family members talked about how strained they felt because they felt like they had to be the activity programmer for their family member because they were not getting it from the facility. Food, again, is very, very important. We saw there is so much dissatisfaction with food in general, but it was the area that had biggest racial gaps all across, looking at every year, and the gap persists. And here's a quote from this African American resident saying, "It's just terrible. I mean, I fuss still about the food so much. It's not so much just the food. It's an hour late. It's 2 hours late. And then sometimes you got residents eating lunch at 2:30. So at 6 o'clock, no one's going to be up to eat because they're going to sleep." So this gets it more like systemic issue that there is a problem with how food is done. But even in this facility that's high proportion Hmong, I mean, they talked about how rice is such a staple of their diet, but they couldn't get for all these years to have it delivered in a way that's A, have it on the menu often enough, and B, to have it, not be, as one resident said, it's so dry, it doesn't matter how much water I drink with it, I can't push it down my throat. And then finally, engagement with BIPOC volunteers and community organizations. I think this is really, really important. And this gets at culture of care in facilities and was actually kind of shocking for me because I have done a lot of work in primarily white facilities before, CCRCs, where I've seen so much volunteers, right, family members, other community organizations coming in. And then with this work, specifically spending time in these high proportion BIPOC facilities, I was shocked that some facilities had zero volunteers. My team members and I were the first volunteers that this facility had. And we received so much pushback where staff were, they didn't know who we are. Like, wait, there are some other people here in the facility, and we had our tags and we got approval from leadership to be there. We had all of our HIPAA and everything. But that was such a stark contrast compared to other facilities that had engaged volunteers because there was more of a culture of openness that people can come and go. Yes, somebody else could be here and they could be in activities. Somebody else could be in a residence room, and they could be here while you are caring for them. And so this need for volunteers is huge. And I just feel like this is an area where we really could target community engagement. And this was also a big surprise. These were high proportion BIPOC facilities located in zip codes that have many residents, churches, and other organizations that are from these communities. But there was no engagement. And a lot of it, when I talked to community groups during the focus groups, they felt that the facilities didn't want them, that they created so much red tape. I mean, I saw it. We went through all the background checks. And then multiple times, my team members felt harassed in some of these facilities. Like, you can't use your phone. Of course, we have our phones out. What are you doing? And taking notes. I mean, there was so much harassment, and they're part of the team. And they would say, okay, I really feel like this is really hard to be there as an external person. And so I'm watching my time. I'll conclude and leave at least 5 minutes for questions. What are some implications here? And there are quite a few. First, I think the main one is that we really need to push for institutional and system level change in how nursing home care is delivered in this country, especially for people from communities of color. The groups that I see disadvantaged most from my work are people who are Black and people who are Indigenous. In fact, Indigenous residents had the lowest scores all across, closely followed for scores for Black residents. What do we see? We see the role of Medicaid. Most of these facilities were high proportion Medicaid, like 90% Medicaid compared to an average of being 60 or 55. There was such drastic lack of resources. My team members would talk about needing to shower each time for being in a facility. The elevator was so old, it didn't work. It smelled, the rugs were old. And these are small things, but when you start cumulatively thinking about a person who is going to live there for 7-10 years of their life, that is their environment that is going to drastically impact their quality of life. We must think about the use of policies such as pay for performance and value-based purchasing to address equity. I will tell you that in Minnesota, I have shared this work with a commissioner, and they have decided to now prioritize pay-for-performance programs. This year was the first year to target it to high-proportion BIPOC facilities applying first to improve these quality of life scores. Because that's it. How are we going to help lift these facilities up, knowing that they just don't have the same resources and capacity to deliver high-quality care? We must develop incentives for these facilities to provide culturally sensitive care. So that's where it comes through pay for performance and a number of other incentives. And really, we need to think about diversification in leadership. What I don't have time to share with you is the differences I saw in facilities where, for example, they had an African American director of nursing. And when residents said, I trust her, and so I am going, their adherence was different. So that concordance of care, not seeing all white administrators and then I'm seeing all primarily Black CNAs, we must create opportunities for upward mobility. We must diversify our leadership if we want to see differences in these long-term care outcomes. We need to invest in these quality of life initiatives, including activities, food, residents being treated with dignity and respect by staff, and then again, incentives for community engagement. I think this is an area where I hope to see more investment in grants that would create incentives for the facilities to open their doors and allow volunteers from the community, and B, for those community organizations to step up, because again, I see so much volunteering in high resource white facilities, and where it really is needed most are in these under-resourced, high proportion Medicaid, high proportion BIPOC facilities. Thank you for your time.
Great, thank you so much, Dr. Shippey. We're now going to begin answering the questions that were submitted during today's presentation. And just as a reminder, you can still submit questions through the questions pane in your attendee control panel. Or if you were in the live classroom, please raise your hand. We'll start with a question from our virtual attendees, and then we'll move to someone in the room. Our first question is, did you find any kind of racism on the Hispanic population in long-term care as well?
That is an excellent question. And I should say that my analyses on quality of life, the empirical data I could show you, are limited to Minnesota, as I said. And in Minnesota, we actually don't have a lot of Hispanic residents in our nursing homes. Most of our communities of color nursing homes, as I said, are Black, Indigenous are the two largest groups, and then also some South Asian groups. So for Hispanic residents, most of them in Minnesota are in our rural nursing homes. So they also receive care in sort of different facility profile. So I was not able to really separate it out in these analyses, but absolutely this work needs more attention. And I also would argue that my findings about people not having English as their first language or not being able to speak English well, and how that resulted in disparate care outcomes would relate to many individuals who are Latino, if some of them maybe for whom English is not the first language, if they're immigrants here in particular. Okay. Was there a question there, Dr. Katz? Oh.
Hi, okay, you can hear me. So I do a lot of activity programming in diverse, like BIPOC community, like memory care facilities. And I noticed what you said, like they have never had volunteers before. It's like very interesting. Something you said that I was interested in is like people were wishing there were more culturally diverse activities. Do you have like any recommendations for those sorts of activities?
Yeah, well, thank you for your question. I will say that earlier this year, I presented at the National Therapeutic Recreation Conference, and we kind of talked about this. How can we move toward developing more culturally sensitive activities? I don't think I have enough time to kind of share it all, but I will say that if you want to follow up with me, I can send some examples from my work. But I really think this is an area where I want to move in, and I hope some of you here listening and in the audience will move in, partnering with culturally diverse communities, family members in particular, residents, as well as community organizations to develop programming, because it's not going to be obviously the same, right? There is great diversity. But I would say I've heard a lot from African American family caregivers for having their loved one with dementia. If they did these 5 things, I know my mom, my dad would react because that's what they grew up with. So I think that's where we need to move, to work with these culturally diverse groups and develop these types of programmings and then start testing them, because at this point I'm not aware of this happening. So I'm sorry I don't have a direct question, but I can send you some examples via email. Yeah, Dr. Katz.
Dr. Shippey, thank you for a marvelous presentation. It was great. Quick question, you alluded to this, but the racism on the part of residents to staff, I think a lot of us have seen that. Can you expand upon that a little bit?
Yes, this was a huge issue. And my work went in focusing on residents, and that's really the focus of my work. But seeing the racism, again, and we know these dynamics where, and I'll say in Minnesota, this is especially profound, where most of our residents are white and most of our direct care staff are Black. And most of our Black direct care staff are African immigrants. And so, racial slurs, especially from residents with dementia. We also have, I'm also doing some work in home and community-based settings, and we hear where, white recipients will not want to have a Black home care aide. But what we've observed in nursing homes, I mean, residents use slurs towards staff. And when I interviewed staff and staff talked about it, it's interesting how many staff were so, I don't know, kind, forgiving, I don't know what other words to use, where they would say, oh, I know maybe they have cognitive impairment. I knew that this would be a hard job when I signed up for, but many of them also talked about the cumulative wear that kind of a racist environment has on them. And of course, we all know we have a crisis with care staff in this country. I know I've shared this work with our provider organizations, and they are all aware, and they are looking for resources. What can we do? But it's also a very sort of ethics challenging issue. How do you address racism among older white residents who are the consumer in the facility toward their often Black, female, immigrant CNA? But I believe this is where we must go as a country, and we must start having these conversations. I know the facilities are being, I've spoken, do a lot of community engaged work. I've spoken to many providers in Minnesota and nationally, and I'm glad you are having this conversation. And I really think this is an issue where there needs to be multi-pronged intervention on the facility level. States must be doing this work, federal, with that our staff who come into these facilities will know that they will be treated with dignity and respect, and they will not be subject to these daily instances of racial aggression. So big issue. Yeah.
One more question.
Yes, I was interested in the root cause of what we're talking about here. Every industrialized country in the world has universal health care except the United States. We have something like 15% of people who are uninsured. Cost play a big factor in what's happening here in the United States in terms of, in quotes, racism in nursing homes and so forth.
Yeah.
It's not, the other factor would be, is it the attitude of people who are working in nursing homes? Is it the mindset, or is the biggest factor cost?
I would say it's a yes and the answer to that question, and we could have a longer conversation if you're interested. So absolutely, research finds that Medicaid as a payer source is associated with worse quality outcomes, right? My work finds that too. We in BIPOC facility are much more likely to be high proportion Medicaid. And so yes, form of payment, Medicaid, the fact that Black people in this country are much more likely to be on Medicaid due to historic racism in housing and other forms of accumulation of wealth, yes, it excludes them from assisted living and other forms of care, and it puts them into nursing homes. That's why we see that now BIPOC people are proportionally overrepresented in nursing homes, because that's where they can use Medicaid. Absolutely, it matters. But in my work in quality of life and in many other studies in quality of care, even when you control for Medicaid, so it's in all my models, you still see racial ethnic differences. So when I showed you that 12-point difference in food, and like 5 out of those 12 was due to facility factors, actually much of that was Medicaid, but also for-profit status. But then there was still 4 some points that's unexplained. And that's going to be in, these microaggressions that we're describing and how people are treated. It's going to be in, language used, environment that's created, opportunities for leadership, seeing who gets what. When residents, Black resident would tell me, I've been asking this for a long time, but the white administrator will coach these white residents when the ombudsman come in and will give voice to their needs and not mine. And so these are some things that are much harder to document, capture in quantitative data. So Medicaid, Yes, it matters. Payment, yes, it matters. But what we are seeing is more than just payment in these racial disparities would be my answer.
Clara, I think we'll go to the break if that's okay with you. Thank you so much, Dr. Shippey. It was a great presentation. Subject very close to many of our hearts. 15-minute break. Please be back at 10:35. So we'll try to get back on schedule. Thank you so much.
Go ahead and grab the headphones. I see the students are already looking into it, and give us your feedback. Thank you so much.
Hi, how are you?
I'm going to have everybody take their seats again, please. If we can get anybody who's outside to take their seats.
No, I was standing, so I have to sit and stand. Yeah, you can stand. She introduces.
Clara, can you hear me and the virtual participants?
Yes, we can.
Okay, thank you so much. So it's my great pleasure now to introduce our next set of speakers. I've known Dr. Greg James for many years. I'm honored to have him here again, and his son, Dr. Nicholas James. Dr. Gregory James is the National Medical Director for ISNP. I think that's the right way to say it.
ISNP.
With Optum, Home and Community. He works with the clinical teams who follow and manage assisted living, post-acute and long-term care nursing home residents who are enrolled in United Healthcare Medicare Advantage plans. Dr. James is a distinguished fellow of the National American College of Osteopathic Family Physicians and has been selected as the National Educator of the Year. Organization also serves as the 2013 president of the Florida Osteopathic Medical Association, also served. He received his Doctor of Osteopathic Medicine and his master's degree in public health from Nova Southeastern University. So welcome back. It's great to have you.
Yes, thank you. It will happen.
He completed his residency in family medicine at Suncoast Hospital in Largo, Florida, and is board certified in family medicine, geriatrics, and geriatrics by the American Osteopathic Association. He's also certified by the American Board of Post-Acute and Long-Term Care. I'm getting a little out of qualifications.
Move on.
Okay, move on. Dr. Nicholas James is a clinical psychologist with the Orlando VA healthcare system. Prior to his current position, Dr. James was a graduate researcher at the Orlando Later Life Developmental Research Lab at the University of Central Florida, where he earned his PhD. Dr. James' work has addressed a large range of topics related to aging and caregiving, cardiovascular risk factors, profiling understudied caregiver groups, and improving the assessment and intervention of caregiver health outcomes. His most recent line of research resulted in the development and validation of the informal caregiver burnout inventory. So I can see a lot of overlapping themes here, and we're all getting some ideas as to what we should do in the future when we all grow up.
Yeah. Be careful.
So I know.
Be careful what you expose your children to.
Dr. James continues to work with researchers and community clinicians to improve the detection and intervention of caregiver burnout. So I'm thrilled to welcome you both. Thank you so much.
Thank you. Thank you. Yep. So first, I'm going to make sure the microphone works. I think I could speak without one, but I know you need it for the virtual. And thank you for the introductions. We appreciate that. We'll take that out of our time, I promise. Let me see if I can advance. Do I have the ability to advance? But of course, I need IT here. All right, that's better. A little delay. I do want to make sure I know Optum's on the slides, but the full disclosure, I'm a full-time employee of United Health Group, the Optum division, home and community, and specifically the ISNP, Institutional Special Needs Plan, the nursing home plan. Dr. Nicholas James doesn't have any conflicts to disclose. These are the learning objectives. I think these might have been provided in advance. The talk is a little text heavy. We understand that, but we're going to make sure at the very end we have our email address. We're going to leave that up for a while. If you want the slides, we'll be glad to send them to you. They might be available through the university as well. But we do want to make sure we get through. It's a big topic. I will say there are entire weekend conferences on dementia and caregiving and how they cross over. I saw one recently I wanted to go to at the University of Minnesota, put on by the Bold Group, and just couldn't make it. So we're not going to give it all justice, but we're going to try to cover the major parts. And the agenda very quickly is I'm going to introduce the topic of caregiving. Dr. Nicholas James is going to talk about burnout. I'm going to come back and talk about resources, and then there's a lot of references at the end as well. And also, Dr. Pandya kind of spoiled my the spoiler alert. Dr. Nicholas James is my son, but so we'll suspend the father and son right now and just call each other Dr. Nick and Dr. Greg, if that's okay with everybody. So with any talk, why this particular problem? Well, this is a couple of years old now, but there's about 34 billion hours of uncompensated care every year in the United States, $500 billion. Now, I know we're talking that much recently in a lot of bills, so it doesn't seem like a lot of money, but it's a lot of money. And that's uncompensated care, which means that if people need the care in the future, we're going to have to start spending it or find a way to find the money for it. And or you have people leaving their jobs to go take care of people at home or even help in the assisted living situations. This is out of the CDC, and there is an increased demand for caregivers that you can see here. Probably one of the biggest ones you've heard in other talks already is that just in 8 years, there'll be 73 million people in this country that are 65 or older. Many of them is needing help with just activities of daily living and IADLs as well. More than 2/3 of the population is going to need some type of help in the future. So just a quick definition of caregiving: activity or profession of regularly looking after a child, chronically ill or disabled person. Caregiving, there are a lot of different definitions out there, but that's what it basically comes down to. And what we're going to distinguish today is primarily looking at the informal caregivers, the person that's unpaid, basically untrained, usually related or a friend, close relative, highly heterogeneous group. Professional caregivers, we'll do a little bit of comparison, but not really going to talk much about them today, are a lot of us in this room. People who decided as early as teenage years we wanted to do this. Then what did we do? We went and we got the training. Some of you are in training now. We have experience, so decades of doing this, as compared to an informal caregiver who may learn on less than 1 week's notice that they're going to be doing this, sometimes days, that somebody in their family has an unexpected stroke and all of a sudden they're the caregiver. They don't have long-term care insurance, and they've made a promise to each other, they're not going to put them in a nursing home. So that is what we're distinguishing here. One of the structural differences is the support you can get as a professional caregiver. You know, I have the ability to see a light at the end of the tunnel in my day, vacation, PTO. I have coworkers, support staff, so many people I can call on to help me, whereas the informal caregivers often have none at all. And even they have family, but that family might be a second family. They might be a second marriage. There might be distancing from their children for one reason or another. They are that person's caregiver 24/7, 365. And then when you look at the training involved, I mean, I'm at this 30 to 35 years and I still think I need help learning things every day, whereas the person who learned how to do this in 2 or 3 days. So you can kind of see where this is going and why we think this is something we need. And while some people call it a public health emergency right now as our population is aging and needing this type of care. So just a quick slide on understanding the caregiver dynamics. Caregiver burden can be separated into the objective, the ADLs, the IADLs, the concrete tasks. What's the person's stress level about all of this care that they have to provide? And then the stressors, what are the secondary stressors? Again, is it a second marriage, a husband or a wife that the kids that are involved are not their children, that are kind of watching over what's going on? Do they have enough funds to take care of them? What are they giving up financially to take care of them? Caregiver burnout is basically a product of these two, and you can see how that can happen relatively quickly, unfortunately, and why it happens so often. In burden, what are some of the common stressors of caregiving? Again, taking on the role unexpectedly. You know, the common case that I saw when I was in practice is a couple that was in their mid-60s. Maybe the husband had a little mild hypertension under control, still a risk factor, previous smoking, and they're planning, they're saving to retire at 65. They've got all the money at 64. He's going to work another year, and then they're going to go visit their grandchildren. They're going to take a trip around the world, and he has a stroke. and it's a hemiplegic stroke. He can't walk, slight cognitive deficiency. You can see where that goes after a few days in the hospital. He's stabilized, nursing home, maybe a week, 2 weeks, 3 at the most. But during that time, the wife or the spouse is still reeling from it, and they've got to take on that role. How do they learn how to do everything that we've been learning for decades in a few days? Well, they can't. Here's how we're going to talk a little bit about how we can try to help them. We can't replace that time, of course. But then also, one of the things that does happen, thankfully not often, but often enough, is what if that male spouse earlier in their marriage abused that female spouse and now she's taking care of him? All kinds of dynamics you can imagine that go on, and unfortunately I have seen that, and we've had to make interventions. So this violates the PowerPoint God's rules of having too much on one slide, but Dr. Nick and I wanted to have one slide, and this is not exhaustive, but one slide where you could say, holy cow, look at everything that's going on with this caregiver all at once. Everything is thrown at them all at once. Now, some of them might get help with one thing or another, but they generally can't get help with most of them, and they do need it a lot of the time. The husband was mowing the lawn and doing the weeding and taking the trash out. Guess what? The spouse has to pick that up or find somebody to do it if they're going to be at home. And that's just one example of one of the many areas. The spouse, male or female, may have been an accountant, a banker, has never had to do any type of first aid even. And all of a sudden they're taking care of a colostomy or a catheter of some kind. So a lot of training that needs to go on there as well. Again, another quick slide from the CDC, a snapshot. Most caregivers are women. About a third of the caregivers actually have been working and have to give up about 20 hours a week or half of their time that they're working, unfortunately. Almost all lack any type of formal training, and as many as 3/4 of them are over 65 themselves. So you have all of those areas, because I saw a study recently that showed at 99.9% of people entering Medicare already have one chronic disease and they're on 2 medications. So this is what we're talking about. That's already many of them. And as many as 1 in 6 already expect to become a caregiver in the next few years. We already talked a little bit about the finances, but it can get significant. It can get very significant when you wanted to provide the kind of care that maybe your spouse provided for you all those years. I feel like I'm taking care of at home. Anything happens to my wife, I'm going to do the best I can for them. But I have some resources that a lot of people don't have. This is just something to show you what's on the CDC site. No special recognition for Hawaii, just that was the first one that came up. But they have little posters. So why like one-pagers in the work I do and showing people a little bit about what's caregiving like in each state. And how is it among women? They have them also for diverse populations, African Americans, Hispanics, big in Florida. So they have many different types of posters. We just had Dr. Shipley do an excellent talk about equity. And so this is just to include it. It's a big issue, not time to spend a lot of time on it here, but there is a link that'll be in the slides, cdc.gov, and talk about barriers to equity in dementia care. It wouldn't surprise you to know that 2 different studies from the Alzheimer's Association showed that Black Americans had the highest level of discrimination. It doesn't pertain just to nursing homes, but taking care of people at home. Can I get home health care to come in? Because they don't always in certain neighborhoods or certain zip codes, or they say they don't do them, obviously, but followed closely by Native, Asian, and Hispanic Americans as well. A couple of more of the posters just for demonstration processes. Turn it over to Dr. Nick. Go ahead.
All right, so this mic is working, right? All right, thank you. All right, so we talked a lot about the different burden factors associated with caregiving so far, but the sort of topic of this is burnout. And I know those words are very similar, but they're going to have some different connections to one another. Burnout is something that has been used really colloquially over the years, right? It's something that we all probably have used to describe an experience that we've had at work or in home life or in hobbies. Oh, I got burned out of this thing. What I'm going to try to do today is bring that a little bit back towards the sort of research side of this and a little bit sort of towards the clinical side of this as well, of how we can use this in a more formal way to understand how this is a stress response and characterize it and respond to it a little bit differently. So again, burnout being used very widely in today's society, especially the last 2 years, almost 3 years at this point, thinking about COVID and how it's impacted the work environment. I think most of us here can probably relate to that, especially in the healthcare industry. So this is a very common topic, but to sort of generalize or bring it back to that research side, I'm going to talk a little bit about the history. For time's sake, I'm not going to go into depth into this, but burnout really wasn't studied as a phenomena until the 1970s. 1975, Maslach and Freudenberger both sort of simultaneously published on this separately, but their work was focused on occupational burnout and specifically healthcare professionals. So those formal caregivers, that's where it started. Over the 80s and 90s, there's this proliferation of research where a lot of different people are talking about this, trying to understand it. There's a lot of incentives from occupation, from workplaces to understand this because it means productivity, it means worker attrition. So there's a lot of research done on it, sort of an explosion there. And so it wasn't really in the 2000s until they started reeling in the research and trying to understand, okay, we have all this data, we have all these different understandings and theories. Can we centralize this? Can we make this a common term? Can we respond to this? What's the field theory of burnout? They didn't really get that. There's a couple sort of main camps nowadays. Again, Maslach is still very involved in this. So if you're interested in the occupational burnout side or any sort of documentation on that, I always refer to looking at her research. But just to sort of show how new talking about burnout is when we think about the healthcare sort of field and recognizing it in our patients, it wasn't until the ICD-10 in 2018 that we even have the term burnout appear as something that can be sort of added to the diagnosis. And even then, it's very specific that this is an occupational stressor. This is not a sort of clinical condition in the same way. So still very novel, but I think there's a lot of utility to it. Oh, is it gonna? Oh, that's weird that it showed all of them first. All right, give me one moment. All right. So I think there's a lot of utility to using burnout to describe this stress response because it's different than a normal stress. It's different than depression as well, which we'll get into a little bit later. It can lead into things like that. But I think the Mayo Clinic has a nice sort of general definition of what burnout is, this physical or emotional exhaustion involving a sense of reduced accomplishment and a loss of personal identity. Sometimes we see things like cynicism and work productivity go in there as well. But sort of taking a lot of the different definitions we have of burnout in, one of the common theme that sort of is threaded throughout all of them is this idea of exhaustion. So within exhaustion, we have a few different domains that I'll show you some examples of on the next page. But thinking about this exhaustion-based burnout, looking at studies of, again, professional healthcare workers, formal caregivers, we know that in the last 2 years we've been trying to track how people have been responding to COVID within the healthcare industry, about 50 to 60% of the healthcare workforce is responding with high levels of burnout. And if this is happening on that professional side, then the informal side for these home caregivers is probably going to be significantly increased as well. So primarily it's an occupational thing. We're going to sort of draw some lines between how informal caregiving has a lot of similarities to the occupational setting today. Like I said, exhaustion is the main theme I'm going to be focusing on to sort of make this bite-sized. Exhaustion comes in all shapes and sizes. Sort of 3 main domains you can break it up into is physical exhaustion, mental exhaustion, interpersonal exhaustion. But no matter which of these sort of singular areas of exhaustion you might see pop up first, really importantly, if it's left unchecked, it's going to become global, right? This is what happens with burnout. It grows over time. It's not something that just happens one day. It's typically a cumulative kind of thing as a stress response. And on the right side of the screen here, you can see some of the examples of that sort of cyclical relationship, how that can sort of spiral upwards. So you could start anywhere on here, but we'll just start at the top. If someone's physically exhausted from the work they're doing, let's say they're a construction worker and they're working hard hours and they have physical exhaustion. Well, when you're physically exhausted, the natural response is to reduce activity levels, to conserve that energy. You start conserving that energy, what are the things that go on the chopping block first? Well, you can't stop working because you need food and shelter. You can't stop taking care of your kids because that's illegal. And so at the end of the day, what happens is you don't hang out with your friends. You give up your hobby. You stop doing the things that you used to enjoy, right? So you stop doing that social engagement. Well, what happens when people stop social engaging? They get isolated. They stop having the hobby that was rejuvenative to them. And so we have mood reduction. And what we know with depression and mood reduction is that that leads into further physical exhaustion and lack of energy and motivation, right? So it's this upward or sort of downward spiral where although only physical, mental, or interpersonal might be the first indicator of exhaustion that pops up, it can spiral over time if left unchecked. That's one of the intervention points when you're thinking about this that you can jump into. All right, so how do we sort of conceptualize burnout, right? Why is this happening? And so I'm going to take, again, because there's the majority of the literature on this is from the occupational side, I'm going to borrow heavily from that and apply it over to informal caregiving. So one of the models that I really like is called the Job Demands Resources Model, or the JDR model. This is a very nice way of looking at this by balancing occupational demands and job resources. So we sort of look at it on old-fashioned scales, where you put job demands on one side of it and weighs it down, and resources on the other side, and we try to get a balance. We try to have resources outweigh those demands. So demands are any of the costs associated with the work, physical, psychological, social, and as those increase in frequency, intensity, duration, those are all going to increase the demands. When we're talking about caregivers, as we're introducing the topic, we talked about burdens for caregivers, right? ADLs, IDLs, the tasks that they're doing, the amount of time they're doing it. Those are all things that could equate over to the occupational demands category. On the other side, we have resources, right? How do we prevent burnout in caregivers? Or sorry, in this is for the occupational setting, and we're going to apply it over. But how do we prevent that burnout? Well, we have resources that offset the cost of being done, right? So if you have construction workers, easy one for physical, right? If you have construction workers who are carrying heavy objects all day, a resource is giving them something to help them carry it, right? A forklift or wheelbarrows to offset that cost and the toll that it's taking on their system, on their body. And so reducing costs, stimulation of job growth, job advancement opportunities, educational opportunities, things like that. And the reward, right? We know the biggest reward that comes up in occupational settings is pay raises, money. But even that has diminishing returns at a certain point. We can't always give that to informal caregivers. So burnout is going to be the imbalance of those two. When demands are outweighing the resources, this is where burnout occurs. Applying this over to informal caregivers, like I said, you can take a lot of this language and sort of part for part translate it over to what it looks like for informal caregivers. They're in a very different setting. They didn't choose this as an occupation, but there are a lot of things that are happening in common. So on the left side of this, we have the JDR model occupational side, demands and resources. On the right side of this, we have the informal caregiver translations. So demands, when we talk about caregiving research, we're usually talking about burdens, subjective and objective burdens that are being taken on. Physical costs, psychological costs, social costs. The unique social and psychological cost is that not only are you going to start having less contact with your social groups, but the person you're caring for might be the center of your social group, right? This might be the person who you spent all of your time with, and now you have to be their caregiver. Now they might not be able to engage in the things that you used to engage in. So there's unique and sometimes more substantial costs associated with the informal caregiving side that we may not appreciate as formal caregivers because we don't have those similar dynamics. Resources, again, we can't pay informal caregivers, but we can reduce the cost with social programs and linking them up to services to help them out with financial planning and healthcare and things like this. So we want to, in the same way we would in occupational setting, balance those demands and resources. If we're thinking about intervening for informal caregivers, we want to think about that balance. What are their demands? What's putting the weight on that scale for them? All right, so outcomes of burnout. If you've been listening to how we've been talking about burnout so far, you might be thinking that sounds a lot like depression. There's been a lot of debate on that. I'm in the camp that they're two separate things, but burnout can definitely lead to depression as a sort of negative outcome in the long term. And we all can think about why we want to avoid burnout. Depression. So prevention of burnout can also prevent that as sort of this outcome. One that's a little bit more complex is when we talk about burnout in an occupational setting, we're often talking about workplace attrition. When is someone going to quit this job because they're so taxed by the work that they're doing? Well, informal caregivers don't always get the opportunity to quit what they're doing, right? This isn't always a choice. This is something they have to take on. The best proxy we really can get to that is premature transfer to long-term care services, right? When are you having the sort of professional services take over because you're so burnt out, you can't continue doing this? It's a very difficult metric to actually get a clear definition of because there's a lot of different reasons that transfer might be appropriate. But what we do know from the research is that the longer we can extend home caregiving, the higher the quality of life of both the care recipient and the caregiver typically. Again, once you're sort of controlling for those stressor demands. We know people what led to the decision to transfer to long-term care services. Some of the leading causes are these difficult, very stressful tasks, but not necessarily medical tasks that they aren't capable of doing, but ones that are very psychologically taxing. Incontinence problems, disruptive behaviors, different this. All right, I don't have a timer on here, so apologies.
You're doing fine.
Good, okay, thank you.
Timer.
Good, okay, get the stopwatch out. All right, so the other area of this to keep an eye on is the impact on the caregiver aside from just burnout. And that is, what are their pre-existing health what's their pre-existing health situation, right? 1 in 5 are already reporting poor health. They're often neglecting their own health needs to prioritize the health needs of the care recipient. If we're looking at just general studies, about 40% of caregivers have a chronic or have at least 2 chronic health conditions. And the surveys from the National Alliance for Caregiving and AARP, about 1 out of 4 US caregivers report directly that caregiving has made their health worse. And there's a really common theme throughout this, which is lack of self-care while you're providing care for someone else. Long pause. There we go. So if we just want to summarize some of the symptoms of this problematic burnout, how these burden factors are really stacking up and creating the stress response, this is just a quick sort of example of some of them. Again, if you think about depression, you might see a lot of commonalities between some of these things and how they might get reported. One of the ones that I just really want to point out is at the bottom here, this quote, whenever I'm running caregiver support groups, a really common theme that comes up is this idea of, I can't recall the last time I did something for myself, right? Whether it's something simple like getting a haircut, or something more important like going back to see your own primary care physician to check in on your health problems. If something develops, again, there's a lot of time priority given to the care recipient because it's a loved one. It's easier to care for others sometimes than to turn that inwards and think about how can I give myself an hour to find care for my husband so I can go and get my things taken care of. And these are primary sort of care things. This isn't just, when's the last time I had time to go do my hobby, which is also important, but again, something that very commonly gets completely cut before any of these other areas do. So these are some of the common sort of warning signs. So how are we going to measure this? Well, like I said, burden is something that's been very widely studied in the caregiver research literature. So I'll give you a couple examples of that. Burnout, on the other hand, has not been widely studied. This is why I went and created the informal caregiver burnout inventory, because there really isn't a good proxy for this. A lot of the occupational burnout inventories that already exist are occupational. And again, that if we're taking those scales, a lot of times they say, like, my relationship with my coworkers, right? My relationship with my boss, or how I respond to the customer. Just changing out the word caregiver or care recipient and boss and customer doesn't really work super well. So Maslach burnout inventory, like I said, is really popular. Copenhagen burnout inventory as well. But the informal caregiver inventory is what I created just to have a screening tool to understand what that burnout looks like in this population. So it's 10 items, 5-point Likert scale. You get a 0 to 40 scale score to understand where they're at on burnout level. And it discriminates from depression, which is important because you could be giving someone a tool like a PHQ-9 or something like that to look for depression, and that could come back negative, but they still could have those high burden factors and that risk for burnout or that burnout occurring because, again, these are not two overlapping, or they are overlapping, but these are not two exactly the same experiences of depression and burnout. If we want to screen for something like caregiver burden, which is also a very important thing to do if you're going to talk to the caregiver and provide care for them, is figure out, well, what are you doing, right? And so the Zarit burden interview is the gold standard in the field for this. This is looking for subjective burden factors, right? What is your stress response to the work that you're doing? And then you can also get those objective factors just by asking, what ADLs are you helping with? What IADLs are you helping with? How much time are you doing this? What have you cut back on your life to be able to do this? And looking at those objective factors as well. Really important. There are some very, very, very burdened caregivers out there. They are not necessarily burnt out. There's some really strong protective factors out there. I know we're sort of in the negative today, but there's a lot of very, positive aspects of caregiving and supports that are out there. And so just because someone is highly burdened or someone is lowly burdened does not mean that they are not experiencing burnout in one end or the other. All right, so if you sort of break down how you might do this in the field, You want to detect it, right? You can do that by looking for burden. You can do that more directly by screening for burnout, looking for depressive symptoms, and then following up with specific questions, right? Burnout is a very complex phenomenon that can be led on by a lot of different precursors. And so if we want to screen for it, once we know it's there, it helps just ask the person, what is causing that? Usually there's a certain level of insight to know, either the lack of self-care or the things that are the most taxing. Sometimes there's guilt with it and you aren't going to get that straight answer with it. But it's important to ask those direct questions, because if you can identify those resources that are lacking, again, JDR model, balancing resources and demands, if you can identify what's lacking, that's where the intervention point is how can we provide those resources, reduce those costs. So if you identify high levels of burden, that's where you want to give resources. If you start identifying burnout, that's where you want to start getting a little bit more specific about that intervention side of self-care, support groups. I know there's a bunch of stuff here about the REACH. This is a different REACH program I'm talking about. It's a caregiver intervention, educational. Savvy Caregiver is another example of it. So there's caregiving specific interventions out there that you can refer to as well. And we're going to go over some other resources in a few minutes as well. All right, just a couple quick examples of how sort of prevalent this is. We know another impact that's happening is subjective cognitive decline. Informal caregivers are more likely, even when controlling for other factors, to report subjective cognitive decline. So there is some sort of toll or some taxing component of this that's leading to these medical cognitive symptoms as well. And then one other interesting one to sort of talk about is grief, because that's a really common factor that we don't see when we're talking about occupational burnout. But sometimes we see people pre-grieving, right? When there's a bad diagnosis, but you're still going to be a caregiver for the next 1 to 2 years. You don't know when that's going to end, but sometimes grieving can start early. Also, there's this latent phase grief as well. And so something to keep an eye on is if you're providing care for a caregiver, is just because the care recipient is either in long-term care services or if they've passed, is that the grief might come on months or a time afterwards. Because again, if you aren't providing self-care time for you, you might not be providing yourself time to really grieve. And so it might come out after the caregiving has ended. So a lot of different special things to consider about the difference between informal and formal caregivers. All right, and then again, a lot of numbers on here. It's important to support caregivers. One of the interesting points, I think, is getting back to the sort of structure of this, is that if we look sort of here at the bottom, we only have about 1.7 million, this is from the 2017 census, but we only have about 1.7 million licensed nursing beds, about 1 million licensed beds in residential care communities. So, right, round up 3 million. Conservatively, if we look at how many caregivers there's about 41.8 million caregivers in the US at one time. About 76% of them are providing care to at least one care recipient. So conservatively, we have about 30 million care recipients out there. If these caregivers burn out, if they transfer long-term services, if they need those professional care services, we might not have the structure to be able to provide support for them. And so this is why making sure that the caregivers are having support and resources before that burnout happens is really important, because there isn't the structure to support if all of them do experience burnout. All right, and so now we're going to turn it over for the brighter side, which is the resources that are out there to actually help with.
Thank you. So I know we're coming up on time, and I told Dr. Pendia we try to get us back on time if we could. So this is the list. I have just a slide, and we're going to go through them quickly. And again, we'll get them to you of just some of the areas that I found fairly quickly on supporting caregivers. I took screenshots of the web pages. I was told I could do that, so I did. The CDC, actually, this is an email I get. Some of you may get on a weekly, at least monthly, but often weekly basis on caregiving resource. And you can see the left-hand side, the very first one is a click on caregiving resources. And this is directly from the CDC, and it has a whole lot more. This was a recent CDC email to providers who are also getting that previous email. And again, we've already brought up that this is an emerging public health issue. That link right there goes into more detail as well. We talked a little bit about lack of diversity, again, covered very well by Dr. Shipley. We don't have to go over that anymore. But it was brought up, again, it's going to be as early as 2050 that more than half of the people in healthcare in long-term care settings are going to be people of color. So we need to basically figure it out, is the bottom line. With smart enough people, we should be able to do that. And also that it would not surprise you to know that minority populations prefer somebody that looks like them, came from the same background, but when that can't happen, at least they've had some training in their culture. That's extremely important as well. This is from the Alzheimer's Association. I saw somebody from Alzheimer's here. I don't know if you know Deanne and Alex, been meeting them, talking with them recently about this. They've got a whole web page in their section on caregiving. And they also have something called Caregiving College. Oh, actually, I should tell you, when you click on, this is just one of several pages of types of programs that people can go to. Many of them are virtual, so they don't have to leave. But if they can get somebody to stay and they can go to the support group, I think it's very, very important. This is something that goes down by county, what's available. Pinellas is the county we're in. If you're not from here, St. Pete, Clearwater area. Hillsborough is Tampa, Lee is Fort Myers, Manatee, Sarasota. I just took the one surrounding here, but there's basically support in almost every single county you can find. The virtual caregiving college, this is something, and it's not unique to Alzheimer's Association. I'll show you another group that has it. But basically, and I don't have the syllabus, but it goes through many of the areas that people can get training on, even in that week to a few days before they take on the role, or once they're in the role, they have something that they can access. And this is all free. It's about how to communicate with people that have dementia, because obviously that has to be different. And this is just a different group to show you the Caregiving College is not unique to Alzheimer's disease. This is something from the Family Caregiver Alliance. It's based out of San Francisco. However, they're online, so it's available for everybody. And theirs is unique in that you could sit down in one day and take all the classes, or you can take it in a series of 4 1 to 2 hour sessions. And in that, it also shows you what some of those areas are. AARP has a caregiving site. You probably wouldn't be surprised by that, but again, that's not their homepage, but when you click to family caregiving, it's there as well, and a lot of different areas. And then from the University of Minnesota, the BOLD, the Public Health Center of Excellence on Dementia Caregiving, they have a conference every year. That's what I was talking about, 2 full days. I couldn't make it this year, but I'm gonna try to make it at some time, just about dementia caregiving. This is a little bit from the BOLD site that you can look up online from University of Minnesota. So this is a quick summary, and I know that we kind of went through quick at the end, but we wanted to have time for questions and answers. And if there's not, I am going to just show you, obviously don't write these down, that's kind of silly. But I do want to get to this that I'll leave up for a second. It's our email addresses if you want to reach out, if you want to copy the slides, we'd be glad to, or try to answer questions. And if we don't know, we have resources either through academics or healthcare industry that maybe we can try to help you with. Thank you, and we're glad to take questions.
Great. Thank you so much, Dr. Gregory James and Dr. Nicholas James. And we're now going to begin answering the questions that were submitted during today's presentation. And just again, as a reminder, you can still submit questions through the questions pane in your attendee control panel. And if you're in the live classroom, please raise your hand. Okay, we'll start with a question from the platform, and then we'll move to one in the room. Our first question is, can you please explain more about the positive aspects of caregiving and how we can leverage them?
Yeah. So it's a great question. There's a really interesting, again, it's one of those topics that we just do not have the time. There's whole presentations that are done on this, but you know, really there's a lot of things that sometimes we get fixated on the negative side of caregiving, right? The impacts and you know how difficult it is to do this. But there's a lot of strength and support that comes from that, right? Bringing together families and communities and resources, and part of the healthy sort of coping component of this is also eliciting those during the caregiving time, to make sure that this isn't just a stressful time that's regretted later on. And so when you look at caregiving interventions or even individual therapy during that time, a lot of times it's focusing on the strengths of the relationship, the meaningful value side of this, and the community support and family support that exists. But again, that's a huge topic. It's really important. We do not have time to get into that fully. But yeah, really great question.
Perfect, thank you. Do we have any questions in the room?
Yes. So kind of pairing off the presentation earlier that had to do with like depression with geriatric populations, with looking at the burnout, did you guys have any like say on how the recovery from burnout versus like recovery from like a depressive patient, like in that sense?
So as far as this line of research goes, right now we're sort of in the detection phase. You know, it's like 2 years ago that I sort of created this instrument. It's not really published on widely. It's, you know, a couple times every decade, really. So I don't have that data yet, and I really hope someone looks into it because, again, if we can prevent burnout, hopefully downstream we can prevent depression. But yeah, that's a good future line of research if anyone wants to do it.
Again, another excellent presentation. Thank you both. We had this question in the last presentation about how much economics either mitigates burnout or not. Can you expand upon that a little bit?
Yeah, just a little bit, and then if you want to take it in it, but you know, when we talk about the resources, right, offsetting costs, that's a major component, right? You know, being able to, sad stories is sometimes, you know, retirement savings are wiped out and things like that because of the cost of care for unexpected, you know, injuries or diseases. And so having resources to be able to, you know, get a professional helper to come in, having resources to buy transportation that's capable of handling a wheelchair, things like that. Modifying the house to make it accessible to the person you're providing care for are all things that not everyone has resources for. And this is, you know, other things, you know, food and access. I mean, the sort of list goes on. Money is a very powerful thing. And so having those resources, it is a resource. It doesn't completely protect you from burnout, but it is something that can be protective of those different burden factors. So that's sort of how I'd summarize that. I don't know if you want to.
The only thing I'd add is just at the beginning, kind of the eye catcher for me was the $500 billion of uncompensated care. That's. I know we've seen things recently on the TV about what we're spending to take care of this or that, and that's great. But this is very important. Well, that we take care of the people who helped build this country and helped us give us the lifestyle we have and the protection we have. And so again, it's another thing we have to figure out. And it also goes to the people that actually have to stop working, either half-time, full-time, to go back and start helping because they can't afford to hire somebody and take care of their loved one or their family member, spouse, whatever else, to take care of them in the way that they need to be taken care of, because nobody does it like us, right? We don't take care of our family like us.
And just as a teaser, I want to alert everyone that our keynote from Dr. Joanne Lynn at 1:15 is going to present some policy options that will hopefully mitigate much of what we're talking about this morning. So you guys have been a great, we just want to amplify that this afternoon.
It's like it was planned.
It was planned.
You want one more? One more?
Okay, do we have another question in the room or shall I go to one from online?
Two more quick ones in the audience.
Okay.
I have a question relating to, I know that some of the resources were through the Alzheimer's Association, but with being that you work with United Health, for the insured, do you offer, how many hours, like if a patient's, you know, has covered with United, how much hours does the insurance offer the informal caregiver for homemaker visits or respite care? How much hours, or, and if it's covered, and how do you help the informal caregiver?
So just to take the time, I'm glad to talk to you like at lunch or something, but there are 100 different plans in every state. Every state has different plans because of different state laws. Some will cover this, and more significantly the other, than such as Medicare Advantage plans, like our ISNP is in the nursing home, institutional equivalent plan, IESNP in the assisted living, provides some of those resources because obviously we want to take care of people where they are, or Optum at Home is a program. Again, full disclosure, I work for Optum. They have those programs. If you have, say, you know, maybe a coverage plan or you have supplemental insurance, it usually does not. If you have long-term care insurance, it does. So there, it sort of depends on what you have, and that's why it's good to look at those. And a lot of people that have traditional Medicare without a supplement, say Medicaid, often will sign up for a Medicare Advantage plan because it does provide some additional resources, some of those. It's a great question, but there's so many different plans out there. There needs to be more of it. I'm an advocate, yes. One more? Okay.
Hi, thank you so much. Such an important topic. I just wanted to announce I'm with the FSU GLEP, and we have a lot of resources for caregivers. The Florida Department of Elder Affairs is the channel, through the area agencies on aging. We're trying to really educate people of what's available to them to kind of demand support services. There is something that I don't think a lot of people know about, and there is a waiting list for it. It's a bit cumbersome to get access to, but it's a monthly stipend for caregivers that are taking care of their loved one living at home. It's only $160 or so, but that can really make a really big difference,
Yeah.
especially for low income individuals. So I want to just announce that if people weren't aware of it. Yeah.
Yeah, it'd be great. Yep. And the only other thing I'll tell you, show you how topical it is I brought this up so I remember. If you get JAMDA, there's an article this month on dementia caregiving and how important it is for some online cognitive behavioral therapy for the family or just assistance. It was done in England, but it really has applications here. And this is this week that this just came out. So I think that's it. Oh, anything else? Go ahead. I think that's it. Thank you very much.
Thank you so much, Dr. James, Greg James, Nicholas James. That was a great presentation. I'd like to now introduce our next speaker, Dr. Laura Wagner. She's a professor at the University of California, San Francisco School of Nursing. Her clinical and research endeavors for the past 20 plus years have focused on improving patient safety and quality in nursing facilities, with an emphasis on helping nursing staff provide care that is evidence-based, ethical, and efficient. She's currently a researcher within the UCSF Health Workforce Research Center, which is a dynamic hub of policy-oriented research and investigation established through support from the National Center for Healthcare Workforce Analysis in the U.S. Bureau of Health Workforce. The aim of the center is to help answer the question, is our healthcare workforce prepared to meet the growing long-term care needs of the aging U.S. population? So please help me in welcoming Dr. Laura Wagner. And Dr. Wagner, thank you so much for joining us.
Thank you very much. Can everybody hear me? Great. So I'm going to be talking about staffing today, and I know that I'm standing between you and lunch. So, and I know we're running a little bit behind. So a few of the slides, the first slides were already discussed, so we can move beyond those. But as was mentioned, I'm a professor at the University of California, San Francisco. I actually started my career when I was in nursing school as a certified nursing assistant in nursing homes and worked my way up and now do research in nursing homes. So as was mentioned, I am Associate Director for Research at the Health Workforce Research Center in Long-Term Care, and we do a lot of policy-oriented research. We are called upon by the feds at multiple times throughout the year to provide rapid response reports, and I'll share one of those with you today. As was mentioned, we're funded by the Bureau of Health Workforce, and we have been in existence for now 10 years, and we just got another 5 years renewed for that. That's our website. The leadership team includes Joanne Spetz, who's the director. She's a health economist. Susan Chapman's our deputy director, and then myself. And then we have a whole host of other investigators on the team. We also have a broad network somewhere right here. Get everybody on here, including Florida State. Paul Katz has worked on 2 projects with us. We have people from all over the United States. Also, PHI has recently become part of our team, PHI International, looking at research that we can do more directly with the direct care workforce. I certainly don't want to spend all the time talking about the different projects. You can go to our website and download any of our reports on this, but we basically do a number of reports on the workforce, all across the long-term care spectrum. So we do home health, we've done work on community paramedicine, especially during the pandemic and the effect of paramedicine in responding during the pandemic response. And then we've done some research on diversity in workforce, dementia care specialists, wages, which I'll talk a little bit about in a few minutes, staffing, which we're going to talk about today. Obviously, that's what I'm here to talk about. And then we had a number of projects during the pandemic to look at the impact of COVID on nurses and also the direct care workforce in nursing facilities. These are our current projects. The one that I'm working on right now with PHI is around the health of the direct care workforce. So seeing what kinds of healthcare access, affordability, and insurance that our direct care workforce has primarily in long-term care settings. And we're going to be submitting this to Health Affairs. We got some really interesting results on the disparities of health insurance when we compare the direct care workforce to those working in other healthcare settings such as hospitals. So maybe I can come back next year and talk about that, Paul. This is a report that we were just asked to do by HRSA around staffing in nursing homes. The link is there. If you email me, I'll have my contact information at the end. I can share the link with you if you don't have access to it on here. So we're going to talk about staffing now. So I think it's no surprise to you that the pandemic had a significant effect on employment and staffing, especially in the long-term care SNFs setting. And the total employment was 13% lower in June 2021 than it was a quarter prior. And similarly, we also know that among RNs, LVNs, and CNAs, it was lower than it was the year prior, in fact, right before the pandemic hit. These declines, as many of you are aware, are associated with the decrease in census. People weren't sending their loved ones into nursing homes because obviously the number of individuals contracting COVID in nursing homes was all over the news. So families weren't wanting to present that as I don't know what, somehow I was muted. And so we also know that 200,000 COVID deaths occurred among the long-term care workforces, among long-term care residents and staff. And you can go on the CDC's website and they provide regular updates regarding how many residents and staff members have died as a result of COVID in the nursing home. We also know that there was a significant amount of turnover among nursing home staff, and this was higher than prior to the pandemic. As well, in late March of 2022, there were shortages. We have significant amount of shortages now that we're facing, most commonly among aides and nurses. And the peak was in January 2022 this year, when 33% of facilities reported shortages. There's a significant amount of contract staff being employed right now in nursing facilities. And we were just asked to write a report on this, the number of contract staff and the impact of using contract staff or agency staff in facilities. The states that were reporting the highest shortages are listed here, with the highest being Alaska at 80%. And the states with the lowest shortages actually were California, Texas, Arkansas, Massachusetts, Connecticut, and New Jersey, with the lowest being Connecticut at 4%. Oops, sorry, skipped one. As we know, some work by Charlene Harrington found that, she's my colleague here at UCSF, we know that higher quality nursing homes had fewer staff shortages. This was in the height of the pandemic. And we also found that there weren't any significant differences among ownership type and staffing during the pandemic. Some of the work that we've done here within our workforce center is looking at the challenges that the workforce faced. We had families dealing with their own illness and death among coworkers, and also just dealing with the death of their own residents. You know, many of the direct care workforce is very closely connected to the residents and family, and seeing them die right before them was very traumatic for our staff, the workforce staff. And so we conducted interviews last year and identified just about the emotional impacts that the pandemic has had on the workforce and the experience of helplessness, anxiety, and fearfulness. So there's a real focus, if we think about ratios and staffing ratios, the focus of staffing has primarily been on nursing staff. So this is the direct care workforce, thinking about regulations for hours and ratios with RNs, LPNs, or LVNs, depending on what state you're in, and then also certified nursing assistants. But we also know there are other staff who are critical to the employment and the delivery of care in skilled nursing facilities. We have physicians, nurse practitioners, therapists, OT, PT, speech therapy, dietitians, social workers, housekeeping, activity assistants, dietary, and the administrator. So when we think about staffing ratios, I think all of you may have wanted me to come here with a magic number of how much is enough, and unfortunately, I've disappointed you in that we don't have that information yet. I'll be sharing some information this afternoon in the panel about what CMS can do about that. And currently, there is guidance set at the federal level by CMS. The states may meet or exceed the federal regulations, but to date, there is no federal required staffing ratio for skilled nursing facilities. There are some guidance around this. RNs are required to be on staff for at least 8 consecutive hours a day, 7 days a week, and the facility must designate an RN to serve as the director of nursing on a full-time basis. But other than that, there's not much written around what's required. There have been recommended staffing guidelines proposed. In 2001, CMS commissioned a study, and this is where the magic number came up from that. They found that staffing increases with ratios of 4.1 hours per resident day, or HPRD as you'll see it written, is provided by all nursing staff. So this is a combined combination of RNs, LVNs, and CNAs. But CMS has stopped short of making this a formal recommendation or requirement. Other studies have validated these recommended staffing guidelines as the minimum needed for safety and quality. And there are state standards, which I'll share with you in a minute, that are less than the recommended staffing. Actually, many states are, and with the exception of the District of Columbia. So if you look at this graph, I have a series of graphs in the next few slides. DC, the District of Columbia, is really the only area that's really following the minimum required hours per resident day. And then we have a number of states following that, and you'll see who the ones are in the bottom, regarding the staffing regulations in 2021 that we should be following. So here's a map to show you just the extensive variability around state requirements for total nursing staff time. This was published earlier this year through the Kaiser Family Foundation. And I just think it's a really good graph to just show how much our country differs in requiring total nurse staffing time within the states. There are also some changes around staffing, which I'm going to share with you now, regarding changes post-COVID. Now, some of these minimum staffing requirements obviously occurred as a result of the pandemic, and some of the requirements have become permanent, whereas others were just temporary. So you can see the states, and I'll share with you the details regarding these states, how they varied. So 5 states adopted a permanent increase in their staffing requirements. And then 2 states retained but restructured the allocation. So let's say taking less hours or hours away from CNA, the ratios for CNA, and added them to the LVN hours. So I think that's what happened here in Florida. 1 state adopted a permanent decrease. That was in Georgia. So I don't know if anyone in the audience is from Georgia, but interested in hearing about that. And also 2 states adopted temporary decreases. So what was the impact of staffing shortages on care transitions? I'm really interested in care transitions. Our residents, what is the flow of SNF residents between hospital, between SNF, going back home? Are we discharging residents either in hospital or back to SNF at the appropriate level of care? And what we found during the pandemic was there were a lot of different difficulties with discharging residents to what level of care they needed to be placed at because of just the challenges with quarantining and isolation of various facilities that were undergoing outbreaks. Also, we know that there were issues when there are staff shortages, when there's staffing issues in a facility, that a facility may not be able to accept new residents. So where are those residents going is the question that one might ponder, especially in areas where there are few facilities. The resident and their family may need to travel further just to receive care. So very much tied to staffing is some of the work that we've been doing in our workforce center on wages. So I'm going to share with you some of the results of that, because we can see that there is a direct link between wages and turnover. And this ultimately impacts the staffing of the facility. So I'm going to share with you some wages, because I think it's really an interesting concept to think about the wages. And so we're seeing that now in the benefits, the research that we're doing around health insurance among especially the direct care workforce, and the impacts of wages. And PHI recently came out with a report, I have a reference in here, just around the living wage and wages and benefits. So RN work settings have been fairly stable over time. From the American Community Survey, we know that about 60%, the majority of nurses are working in hospitals, obviously, but about 11% of RNs are working in nursing homes and residential cares. I should pause and say that the slides I'm about to share are primarily registered nurses, the wages around that, but certainly applies to other staff working in facilities. From the National Sample Survey of Registered Nurses in 2018, about 4.4% of nurses from that survey were working in a nursing home or long-term care setting. Long-term nurses that work in long-term care settings are often older. They earn less than nurses who are employed in other settings. You can see there's about a $10,000 difference. They are less likely to have a bachelor's degree or a higher degree, such as a master's degree or doctorate degree. They are more likely to be internationally educated, and they're also more likely to be a person of color, however, less likely to be a Hispanic, based on the data that we've been able to identify from our surveys. So one question that we wanted to ask, and it's really wonderful that there's been so much discussion this morning around, systemic racism and just the shift in our changing population here in the United States. I think it's really great that we're having this discussion in long-term care, because I see the work that's being done on diversity, equity, and inclusion, and want to really infiltrate the long-term care setting, just given the population that we care for, but especially our workforce. So we wanted to see whether there were wage differences among racial and ethnic groups who are working in nursing home settings, because we have some prior research to show that Black and Hispanic nurses who are employed in hospitals earn less than their white and Asian counterparts. And since, as I mentioned earlier, we know that long-term care nurses earn less than hospital nurses. So we wanted to ask the question, does race and ethnicity explain lower wages in long-term care, especially among non-white RNs and immigrant nurses? And what other factors account for lower wages in long-term care, which I think is the really interesting question that we found. So what we did, this is our paper from Medical Care. I'm happy to provide the reference for you. This was published by myself and Joanne Spetz and Tim Bates, who helped us with the analysis. And we were looking at the association of race, ethnicity, and wages among nurses working in long-term care. So I'm not going to go into all the methodological details for you, but just to say that this was from the National Sample Survey of Registered Nurses. These were employed nurses. We had various cut points of who we were going to include in our study based on how much they were working in the setting that they were in. And we came up with a really robust sample size of 15,000 nurses in this. And we had a whole number of variables that we were looking at in this. So what did we conclude? We concluded that lower wages among nurses working in long-term care settings were not the result of race or ethnicity or among internationally educated nurses. There weren't any differences with that. We did find that nurses in long-term care experience lower wages, not surprising, so this confirms prior research. Yet this difference was not associated, as I mentioned, with race or ethnic or international educational differences. However, we did find that the main cause of wages was that long-term care settings do not reward nurses for their level of education. So diploma or associate degree nurses make the same amount as a baccalaureate prepared nurse, for example, just to compare the 3 levels of registered nurse training. It also does not reward experience based on level years of experience. And it also, we found interestingly that we want to do some more research on, does not reward for unionization very much. So there may be some differences, or there are some differences in wages based on nurses who are in a union. So as mentioned, lower wages were associated with part-time work. We know that the nursing, there's a lot of in and out of, just based on the fact that the nursing workforce is primarily female. They may need to work part-time or per diem if they're taking care of their families, for example. Lower wages were, as I mentioned, associated with less experience, union representation. We also find regional wage differences. The biggest disparities were that the wages were lower in the South, such as Florida, Georgia, Alabama, and higher in California, obviously, given our cost of living out here. One interesting limitation that we did want to note that we think possibly the reason for why there wasn't a difference in wages among minority nurses is that minority nurses, nurses of color, were more likely to work in urban areas, and urban areas tend to have higher wages due to cost of living. So we weren't able to account for that in our analysis. So I want to talk briefly about the impact of COVID-19 on wages. So 4 states adopted laws to increase wages during the pandemic. And this was conditional on receiving higher Medicaid reimbursement rates. And 3 states adopted temporary wage increases or bonus pay to recruit or retain staff. We know that it has been exceedingly difficult to retain staff, to have those correct staffing numbers. And as I've mentioned, we're currently doing that work right now with contract staff. So would love to share that information for you once it's available. So here's some discussion around this. So future staffing considerations. I really have not discussed in my talk today. I was told by Paul that I was to come here and talk about SNFs, but really want to think about what are some staffing considerations around home health agency staffing requirements, also assisted living facility staffing requirements. There is very, very little research in this area among these 2 long-term care type settings. I've identified I've outlined some of the regulations and requirements here in Florida. Certainly there's probably some of you in the audience who know this staffing information better than I do around Florida. But as you know, Florida has several types of assisted living facilities, including congregate care, limited nursing service, and limited mental health. And there are some regulations required for this, as is mentioned here. And so it's really interesting to see, again, we think about disparities of staffing requirements in SNFs. There's even greater disparities among staffing in home health and assisted living settings. So what is the outlook for the long-term care workforce? Well, as I think we're all uniquely aware of what's going on, the pandemic has really catalyzed some short-term actions with these policy changes. And I want to put this charge to you that I think these can translate into viable improvements for our workforce. As many of you know, during the pandemic, especially at the beginning, the staff were getting hazard pay, bonus pay. There was, we were hearing from direct care workers, they were getting free meals, free parking, and then all those benefits, I could go on and list what those all were. They just sort of unraveled at some point. And so thinking about how can we retain some of the actions that happened during the pandemic to help staff members feel like they belong in a facility, to help with staffing, to help with retention, to limit the turnover. Another thing that came about during the pandemic is paid sick time. There are, that's a whole other study that we need to conduct around sick time across the United States. There's extensive variability around requirements of our facilities required to pay sick time when a staff member is sick, especially if they have COVID. So that's another change that occurred during the pandemic that we need to think about is the requirements for sick time and paid sick time especially. As I mentioned, hazard pay, the bonuses that staff are receiving, those have not retained. We're instead trying to see, looking at the impact of contract staff, as I mentioned. Also, the access to telehealth. I am interested in hearing some thoughts from some of you in the audience who may have seen an explosion in the use of telehealth as a result of the pandemic, and maybe how has that affected staffing? How has it impacted especially the nursing staff, being able to have conversations with providers if the provider is not able to come in on a certain day. We've really increased our ability to have telehealth visits and taking a computer right into the room. And so this is a positive benefit that, these are all positive benefits as a result of the pandemic that we can think about. And finally, as I mentioned, the health of the long-term care workforce. We know that some of those in our workforce have died, have become sick, are dealing with long COVID. We've heard from staff members who've had to apply for disability, long-term disability, because they were sick from the pandemic, from COVID, and they're no longer able to work. So thinking about the health of the workforce, and as I mentioned, we're currently doing some work on that area, pre-COVID data, but it certainly makes us pause and think about the lack of health care that we're offering our workforce in long-term care. Also, we need to think about efforts to invest more federal and state dollars in Medicaid. And this is really to better equip the sector to meet with the current demand and withstand future crises. There certainly are numerous challenges and opportunities moving forward, and hopefully I've identified some of those opportunities for you, because I'm an optimist and I like to think about thinking about how can we make long-term care better. I like to be an optimist and thinking about that and the opportunities that we have that are with us today. So now I'm going to talk about, unfortunately, some of the challenges. As we know, over the years, our types of residents and their acuity levels have changed dramatically. If you look at a SNF facility today, it is not like the acuity of our residents are not the same as what they were, a decade ago, even two decades ago. So thinking about this shift in acuity levels, how has that impacted staffing? Do we need a different level of staff, more RNs and LVNs, for example? We certainly need to do more research in this area around the level of acuity of the types of residents today in SNFs. I know I don't want to, there's a spoiler alert here, but we'll be having a panel this afternoon to talk about the recent report, the National Imperative to Improve Nursing Home Quality, honoring our commitment to residents, families, and staff. So I'll be on the panel later today. I won't go into too much detail about this right now, as I'll be talking about staff makeup later, but really thinking about the need for direct care registered nurse coverage, a full-time social worker, increasing specialization of infection control, especially as a result of this pandemic, and also hiring qualified personnel at higher levels, including expanding the use of advanced practice nurses, nurse practitioners, physician's assistants, clinical nurse specialists even. So as I mentioned, I'll talk more about this later today. These are some of the opportunities, especially for research that we have on staffing. So expanding the research on minimum staffing and also optimal staffing ratios. This includes what are the needs on weekends and holidays. And I think that's an interesting, we don't talk about the staffing ratios on weekends and holidays, but we know we are often most challenged on those days with staffing. And also staffing requirements, as I've mentioned, around acuity level or resident case mix, the type of staff needed for the care of special populations. The last talk that you heard was on burnout and caregivers of dementia patients, certainly thinking about the training requirements for staff, who are caring for those living with dementia. I currently have RO1, it's a federal grant that's looking at dementia care training requirements among staff in the long-term care setting. And again, there's just huge disparities across the United States around number of hours that staff need around dementia care training and the types of training that's required with caring for this special population. And I was really intrigued by the last talk around burnout, because if you have staff that are burned out, that's going to impact our staffing, especially if there's, we know that there's high turnover. So thinking about how can we improve and enhance the training of, especially in dementia care residents and dementia care special care units. Also with rehab units as well, just what is the staffing requirements on rehab units and what are the training requirements on rehab units. And as I mentioned, I hope some of you come away today thinking about how can we do more research on workforce projections and staffing ratios in home health and assisted living facilities. We haven't done enough research in those areas, and also thinking about the acuity levels of our clients who are living in assisted living facilities and who are receiving home health services, and what the staffing ratios are required for that. Some challenges, I'm going to talk about wages now. Regarding wages, as we know, our staff in SNF settings, this certainly impacts the staffing. There's low compensation, heavy workloads. I can tell you, working as a CNA, when I was through nursing school, it was the heaviest job I ever had. Just like my back hurt every day. So just thinking about the heavy workloads of the direct care staff, especially. Our scheduling challenges that we have, inadequate oversight by management, and also, just as I've mentioned, limited training and career advancement. There are some opportunities for that, which I'll share with you in a moment around career and career advancement. We also, unfortunately, being in long-term care, we have to compete for workers against employers, especially hospitals. Wages are higher in hospitals. Benefits is what we're seeing, better benefits, better insurance benefits, sick pay, just much better in hospitals. I even saw during the pandemic, I work at a medical center as part of UCSF, and the amount of benefits that the direct care staff were getting were just unbelievable during the pandemic, and I was seeing very little of that translate those types of benefits in the long-term care setting with staff. Long-term care staff really felt left out around some of those benefits that were being offered. There was one person that we had interviewed as part of our survey. They went to McDonald's because McDonald's was giving out a free meal to staff, healthcare staff, and they were told that because they weren't working in the hospital, they weren't eligible for their free meal. And so we see this disparity of even out in the public around long-term care staff, and certainly how can we build that staff up and give them the opportunities. As I've mentioned, wages are lower than in other settings, and this is despite workers even having more experience. So we need to reward those nurses who we are able to retain, those staff members who we're able to retain in the workforce. And as I've mentioned, wages are probably the reason for the higher turnover in long-term care. So that's really why I wanted to, include this part around in the staffing talk today about wages, because wages have a significant impact on how we're going to retain our workforce and impact the staffing. And long-term care settings should reward education and experience. We know that quality of care is linked to education and experience, and we know that nurses especially leave their jobs when they don't feel rewarded. So what are some opportunities? These are really opportunities that PHI has recently published in one of their reports around a living wage, which I'll mention in a moment, but thinking about a national compensation strategy that aims to ensure a competitive wage and especially benefits. What we're finding is huge disparities around benefits and the healthcare. How can we take care of this workforce when we compare it to other healthcare settings? Establish a permanent living wage. We had, as I've mentioned, during the pandemic, we've had staff, their wages were increased, but those are, going away quickly. So we need to think about how can we increase workers, especially the direct care workforce, to have a more permanent living wage. Many of our direct care workers especially are living in poverty. And so we need to think about this workforce. They are the largest, yet they're the lowest paid and the most invisible workforce among the SNF long-term care. And also thinking about hazard pay and sick time benefits, universal access to that. And as I've mentioned, states enacting permanent sick leave laws. This could be similar to the Family Medical Leave Act, for example. I know we've done it in California, and I would love to see other states follow that. So I'm going to sort of tie this up talking about burnout, given that you just had a talk on burnout. So we have all these themes really. You guys did a beautiful job putting this conference together, because just all these themes really fit in with each other. So burnout, there's challenges. We know that what we're finding in our research is our mental health benefits for long-term care staff are not often enough, and they're inequitably even distributed among employees. So employees at the higher range, such as in administration and leadership, may have different levels of access to mental health benefits, for example. And we know that, as I've mentioned, our healthcare workers, especially our direct care workforce, has experienced a lack of emotional support from their employers during the pandemic. We heard some really heart-wrenching stories about the direct care workers working at the bedside, taking care of people dying from COVID, and the lack of emotional support that they received from their supervisors. And I think everybody knows, if you're watching the news, just reading about or hearing about the Great Resignation, we saw a lot of staff leave the workforce, especially in home health. We've seen that, and offer different career changes. So we did look at some data on where there were changes of careers among, excuse me, staff working in long-term care and maybe going to other service industries. We've looked at some of that data as well. Oh, here's some opportunities around burnout. We have seen, I work in a school of nursing, and I can speak, I don't know if anyone else in the audience is at a school of nursing, but I can speak to the ones, especially my school and other schools around the country that I know of, have seen record enrollments and applications. It's probably more around the application process, because we do have a pipeline issue, a lack of nursing faculty to be able to accept everyone, but we've just seen a record enrollment in RN training programs. So that's an opportunity. The pandemic really put to life the value that healthcare plays in improving our public health initiatives across the country. And so we've just seen incredible enrollment changes and applications of people who want to pursue a career in nursing. And I think that's an opportunity for us to really take advantage of. We've also seen facilities. I've heard of facilities offering burnout prevention and intervention programs for staff, which I think is really wonderful. So I'd like to see more models of that and best practices be offered out there, and also bring to light what those programs and the impact that they're having on staff. And as well, as I've mentioned about the current work that we're doing, just discuss how mental health coverage in insurance plans with these facilities, how it's implemented and how it's financed, and if staff do have mental health coverage as part of their insurance plan. So in conclusion, as I said, I'm an optimist. I like to take these challenges to staffing and turn them into opportunities. Would love to see more research that has looked at evidence-based interventions. We're hoping, as I'll mention this afternoon, that seeing what impact that CMS and the other federal funding could have around funding policy research. And this is especially in home health and assisted living facilities. Also improving wages and compensation, and offering career development opportunities where we have CNAs who want to further their education in the pipeline. So what opportunities can we have to help CNAs specialize, for example, as a dementia care specialist, or help them go back to school to be an LVN or an RN, or help a registered nurse pursue a doctorate in nursing practice. So really thinking about what can we do as a in long-term care to help with these career development opportunities. I'm currently working with a community college south of San Francisco in Salinas, which is called the Salad Bowl of the world, and they have an LVN RN training program there, and most of the RNs in that program that are LVNs are working in long-term care, and they've had specific outreach to the area nursing facilities because it's such a huge need, and there's just a limited pool of people. Again, when you are in a rural area, you have a limited pool, so you need to offer these career opportunities. And ultimately, all of these benefit our workers, our residents and families, and especially our future residents, which include all of us in the audience. So hopefully, I'll take some questions now, and I'm happy to talk further. And thank you very much for the opportunity as well.
Great, thank you so much, Dr. Wagner. And so we're going to begin answering the questions that were submitted. And just as a reminder, if you do have any questions, go ahead and type them into your questions pane, or in the room, just raise your hand. So our first question for you is, the staffing data available from prior years, would that take account of higher acuity and medical complexity of nursing home residents?
I'd be interested in hearing more about when you mean staffing acuity from prior years within the facility. Is that what the individual was speaking of?
Ratio data was from maybe the first first decade of 2010, or maybe later. But since then, as you mentioned, the acuity of nursing home patients has been much higher. I mean, we're treating people who would have been in the hospital years ago, and now they're in the nursing home, and the ICU patients are now on the med surg floors. So it's all kind of trickling down to long-term care. So have your studies taken account of that? And our current recommendations for staffing might be different as a result.
Yes, yeah, thank you. That's correct. So the number that I quoted earlier is very old now. It's almost 2 decades old. So we certainly need to do more research in this area. And as I mentioned, and I'll mention this afternoon, expanding, doing large studies. CMS just commissioned, as a result of the report that will be on the panel about this afternoon, they just commissioned the report around staffing. So it's in real time, it's happening right now to see if that number needs to be changed.
Sarah, we have a question from the floor here. Is that okay?
Mm-hmm.
Go ahead.
Hey, Laura.
Dr. Katz has a question.
Is that Paul? Hi.
Yeah. Thank you very much.
Yeah.
And I'm glad you went into home health and assisted living. I'm sorry if I restricted that unknowingly. Yeah, like you, I'm trying to be an optimist, but when you look over the last 20, 30 years with the staffing concerns that you really nicely articulated, a lot has not changed. It's getting worse with higher acuity, as you mentioned. Why doesn't CMS, I know the answer to this question, but I'm going to ask it anyway. Why doesn't CMS just mandate that everyone have 4.1 hours per resident per day? They are very used to giving all of us unfunded mandates. Maybe this will move the needle a little bit, but it seems that the political winds are never strong enough to make this happen.
Or the political winds are constraining that from happening as well. I mean, that might be my answer. We have lobbyists that are trying to, and owner operators that might be trying to prevent that from happening as well. I don't know if that's how you would answer it, Paul, but that's where some people might think that there's a lot of other opposing forces at play that are preventing those mandates from coming into place.
We have another question from the floor.
Hi, I'm Laura Smith. I'm a College of Nursing faculty here at Nova, and thank you. I was curious about the kind of crossover in pay increase. So we're therapists, physicians, other groups of ancillary care providers given an increase in pay through the COVID pandemic, and what is happening with those wages? Because I know for the nursing colleagues, they're losing their pay. I just wonder if that's across all disciplines or is it specific to the nursing?
That's a really great question. And that's something I can take back to our workforce team. We only looked at nursing wages as part of this and direct care staff wages, but certainly we could assume that it also impacted other ancillary departments as well. And you may know that many nursing facilities contract out their therapy departments. So it may be exceedingly difficult to get that data if we want to specifically look at therapists. Good question.
Any other questions?
We don't have any online ones at the moment.
Great. And I'll have more to say about this topic this afternoon in the panel as well. I'm really looking forward to sharing more ideas around staffing and the workforce.
We have one more question.
Laura,
Dr.
it's Paul
Katz.
again. Sorry.
No, it's okay. Love talking to you, Paul.
A lot of the data that you gave us was RN. LPNs are the dominant nurse force in assisted living. I'm just wondering, is the research catching up with the LPN? Because the dynamics may be a little different with LPNs.
Mm-hmm. Yeah, definitely. We did not, the data that I shared with you was from a publicly available database. We weren't able to look at wage data among LVNs. They're not in that database, especially if they're in assisted living setting. So we might have to look at something around the American Community Survey to see if we can get some of that data. That might be our best bet around looking at some wage data. Great question.
Any questions from the virtual attendees, Clara?
Not at the moment.
Okay. All right. In that case, I'm just going to remind everybody in the room here, we have a lot of interesting videos, tools you can take for teaching. Please help yourself at the back. Some giveaways, gifts. Help yourself. And we're going to take a break for lunch till 1:15. It's downstairs in the cafeteria. So back to the elevators on your left, down to the first floor, and you'll be guided from there. So thanks so much and enjoy your break.
Okay, Dr. Katz, are we ready to go ahead and get started here?
Clara, can we give us a couple more minutes? We're just assembling.
Yep, sounds good. Perfect.
Okay, Clara? Clara, you ready?
I am. Welcome
Okay.
back, everyone. I hope you all had a lovely lunch break and are feeling revitalized for the second half of today's symposium. I would like to introduce Dr. Paul Katz, Professor and Chair of the Florida State University College of Medicine's Department of Geriatrics and Program Director of FSU's GWEP. Over to you, Paul.
Thank you, Clara. It gives me, number one, I want to thank not for our virtual audience, but for those in attendance here for a great lunch that our co-partners NOVA have given us. So thank you very much. And those of you virtually can see me better than the audience who just seen my hairline, I think, because of the, I'm of short stature. We'll leave it at that. Today, as I alluded to earlier this morning, today's presentations, which were great, all I think have led to a common theme that our next speaker, Dr. Lin, will elaborate upon, and it's for really the need for change. Let me, I have the pleasure of introducing Dr. Joanne Lin. For those of you who are not familiar with her work, she's a nationally renowned geriatrician, educator, quality improvement coach, and researcher. She works half-time with Representative Tom Susi as a health and aging policy fellow and consults with long-term care reform endeavors nationwide. Dr. Lin was one of the first hospice physicians in this country. Has been a tenured professor at Dartmouth and at George Washington, a medical officer in the Center for Clinical Standards and Policy at CMS, and director of the Bureau for Cancer and Chronic Disease in the Public Health Office in Washington, D.C. Joanne has published 300 professional articles and 80 books and chapters, as well as dozens of white papers, court briefs, and guidelines. In addition to her MD degree, she has a master's in quantitative clinical sciences and a master's in ethics and public policy. She's a member of the National Academy of Medicine, a master in the American College of Physicians, a fellow of the Hastings Center in the American Geriatric Society, and a member of the National Academy of Social Insurance. Her work focuses on making it possible for Americans to live comfortably and meaningfully when disabled in the last phase of life, much of what we've been talking about this morning, at a cost that the person, the family, and the community can sustain. And she will expand on the WISH Act, which she'll be talking about. And I also want you to know that she has written the Handbook for Mortals and Medicaring Communities. I'm sorry, Joanne, we have no time left because of your introduction, but we'll still fit it in. It really is a pleasure to have someone of Dr. Lin's stature, experience, to really give us something exciting to think about and to advocate for. So without any further ado, Joanne, you're on.
Thank you very much. I think it was President Jimmy Carter who said that when you get truly famous, the introductions become shorter. So you can keep that in mind. Let's see, let me try this again. There we go. So, yeah, I get the honor of being able to bring you a somewhat different kind of talk than you usually have in a geriatric symposium. I've really appreciated the ones this morning. Really helped set me up, including being burned out over having just moved over 2 weeks with a broken arm. um, but what I really want to talk to you about is our need to adopt a somewhat new role. That is to really become advocates for real change in long-term care. There's a famous rule or saying in international economics. It's called Dornbrand's rule. And the claim is that every crisis takes longer to arrive than you had predicted and then accelerates to disastrous proportions much faster than you could have expected. And I think that's where we're headed here. We know that we are headed for a major disaster. And, it was initially predicted to hit around 2029 or 30. Probably will take a couple more years because we'll accommodate one way or another. And then it will be blistering. So I'm going to walk us through some of the things that I think we should change, and then I'll be eager to hear what you think in a question and answer session. Much of these next couple of slides was actually dealt with very graciously by Dr. Greg James, so I won't spend much time on it, but it is very important, that last bullet, that before the pandemic, the projection was that more than half of middle income seniors will not have enough financial resources to pay for food, housing, and medical care. There's a special in the Kaiser Health News today interviewing 3 people who are at the breaking point today. But when we have more than half of people who paid their bills, behaved themselves, did the right things, unable to afford food, housing, and medical care in old age, will we actually tolerate that? And that will come sometime in the 2030s. Well, it's important to remember some of these facts. I'm sure you can get these slides later, but so you can get them yourself or go to Medicaring.org, and there's a list of all these sorts of things there. But we have really set up the situation for calamity. And that was predicted. It was predictable in 1960 when all the boomer babies were off to school. But the country has dragged its feet and kicked the can down the road and has failed to reestablish any reasonable way to deal with old age. So where are we headed without change? We are headed to absolute disaster. As geriatricians and as people who take care of elderly people, will we really be comfortable living in a world in which we can prescribe $20,000 or $30,000 a month drugs to people who cannot get supper? Will we really be comfortable putting people in the hospital because they were exposed to the elements without housing? We need to be speaking up now. We need to be pushing our legislators to stop kicking the can down the road and seriously deal with the financing of long-term care and the organization of long-term care, both of which were developed at a time when very few people made it to advanced old age. Most people had a relatively short period of disability, and they were living with family with lots of potential caregivers in general, none of which is true now. And when the numbers have doubled between 2015 and 2035, we will really be in a tough spot. So what is already being done? Well, here's the things that are hot right now that everybody's talking about: nursing home staffing, infection control, specialty palliative care. You can see many of these things. They're terribly important. I agree with all of them. They are not particularly likely to happen in the present political environment. They are not particularly strong changes, and whatever we gain, we will lose when the financing becomes implausible. Very hard to deal with. We want it to be different. We want to believe that it will be different, but it won't be. So I have two things that I think we really need to do. One is to push a really different demonstration project. We need a score, 20, 30, something like that, geographic communities that are willing to really work on generating a very different elder care system. Within the next few years, get underway. It'll take 5 to 7 years to really show that you can do it. But I have a relative right now getting a $20,000 a month drug at age 96 with 2 cancers and moderate dementia. And the family is being bankrupted with the costs of home care. The priorities have to include getting people food, housing, and interaction with others, purpose in life. We can't just be throwing expensive drugs and hospitalizations at people. Why geographic? Because when you are very dependent and in old age, you are very much reliant on what your community offers. What is the workforce? What is the housing? What is the food delivery? How bad or how good is the medical care? You can't go somewhere else. You can't just commute to 100 miles away to get something better. You are tied to your community. And right now, the social services the supportive services are dramatically underfunded. And the medical care is wildly overfunded. So and then the other thing we need is the better financing. And I'll walk you through both of those. What is a good care system should be able to promise to those with serious chronic illnesses? These are the things I think you should be able to promise, that you really thought it through. You've got a system that knows how to get the correct treatments, the correct diagnoses, that symptoms will be relieved. There'll be no gaps in care. There'll be no surprises because most things are predictable. That you'll customize care to the person's preferences, that you'll honor the family, and that includes dear friends and others who are willing to be supportive. You'll help people to live as fully as possible with their disabilities. At the present time, the hospitalist can promise that they will try to stumble through some of this while the person's in the hospital. If the person is lucky enough to have a primary care doctor, but one who won't go to the home, the primary care doctor can kind of promise to kind of do some of these things, but not if you're in the hospital, and not if you're in the SNF, and not if you're in hospice. So the only place you can really get this promised to elderly people who are disabled now is in PACE, and very few people are in PACE. So why a geographic population? Again, it's because most of what you rely upon is tied to your community. You can't fix it for just one patient. You can't fix it for just one insurer. You have to do it for everybody living in the community, including the people that, as Professor Shipley pointed out earlier, the people who are traditionally discriminated against. You have to, if food delivery is available, it has to be available to everybody in the community. And if it's not available, there are waiting lists for everybody. You can now know a lot about an individual community. We don't think this way. We think, is this nursing home doing a good job? Sometimes is this doctor or this hospital doing a good job? Here's an example of what you could be learning. This is exposure to benzodiazepines among people who are older than 65 who are known to have cognitive impairment in Miami-Dade County. And yes, people who have 2 or more ADLs, that's self-care need, 2 out of 5 are on benzodiazepines in Miami-Dade. If you have self-care need and cognitive, you get just about the same. You can see here in the last year of life, about 1/3 of people are on benzos. This is a drug that we should not be using in the elderly. And there you go. You can Antipsychotics, you can see, is roughly the same. Severe pressure ulcers, not a surprise. If you're drugging everybody, you're going to have lots and lots of severe pressure ulcers. These are stage 3 or 4, not stage 1 or 2. These are stage 3 or 4. Full thickness or through to the bone. You can look at your county in relation to others and compare all sorts of things. I'm not going to spend a lot of time on this, but the opportunity that you could know a lot about your community. You could know a lot about the providers in your community. These are all for fee-for-service Medicare. But you could see that, that doctor down at the bottom is spending double what everybody else is, sometimes triple. And if you look at the spending line, if you look at how many people are frail, that doctor's taking care of lots and lots of frail people, maybe as a nursing home doctor. But you'd want to know a lot about how your different practices are working. In Sweden, everybody is in a registry, and the registry is geographic. So there's 3 parts of this county. This is Jönköping, Sweden. And you'll see that they put out in public various comparisons. So here's antipsychotics. And you can see that this township is way more than some of the others in terms of how many people are on antipsychotics. And you can bet that the city council meeting in this county is going to take this up because you know that they're way out of line. These others might take it up as evidence that they're doing a good job. You can measure a dozen things that are relevant geographically. So here's spending. Now this is Miami-Dade again, to no surprise. They're spending lots and lots, on various populations. But you'll notice that they actually go under the national average of counties on skilled nursing facilities. Well, that's curious. Lots of home health, fair amount of hospice, lots of inpatient, but not a lot of SNF. Well, if you were trying to design things for your county, you'd want to know that. So we need affordable excellence for everybody in a geographic population. And in order to do that, you need an entity that will monitor these things and manage toward excellence, set priorities, evaluate progress, respond to the residents, and they need some authority and some funding. We do not have this. Virtually every other country has this. We do not. We somehow think that the hodgepodge of all the arrangements we have, the different insurers, the different hospitals, the different doctors, the different ACOs are somehow going to all come together and magically do a good job. But no one's actually measuring that. And that's for a population, of course, that needs all those different services. So we need the data, we need the leadership. The biggest thing missing is the will. The biggest thing missing is people being angry enough, motivated enough to say, this has got to change. We have got to find ways to do it better. That will require flexibility and regulations and financing, but we probably in most parts of the country already spend enough. We just spend it stupidly. Here's my mother at age 90. She was 94 at this point. She picked up a small suitcase and felt something give in her back. Being an old radiologist, she said, I have fractured D12, being of the era in which it was dorsal 12 rather than thoracic 12. Over the next couple of months, I convinced her to spend only $10,000 on the stupid array of services that were being provided to her. Her orthopedist would not provide any pain medicine. Her primary care doctor had to see her in the office. But I did persuade her not to have kyphoplasty, the injection of the vertebra, which would have run up another $20,000. This, remember, is in 2015, so these would now all be expanded. If I had had my way, she would have spent about $5,000 on excellent home care. She would have had some pain relief. She would have had some physical therapy, and she would have gotten back on her feet just as fast. That's the kind of waste that we have built into our system now. If we could put that into supportive services, and coordinated care, and comprehensive care planning, then we probably could do excellent care at roughly the same cost we now have. So we have to build the new model, and the new model is probably geographic. But again, who has the will? Who's even talking about this? Who is even proposing that we do something different? CMS is still thinking that competition in elder care is going to guarantee quality and low cost, against all evidence that that ever worked. So what's my second priority? Long-term care financing. Because no matter what else we get in the short term, if we get a mandate for better staffing, if we get a mandate for career ladders for nursing home aides, if we get infection control being better in congregate facilities, they are all going to fail at the point at which we have half of the elderly disabled population unable to afford a roof over their heads. It is a very simple observation that when we have twice as many elderly people with 2 or more ADLs or cognitive failure, and we have not developed any appropriate financing, we will go back to approximately where we were in 1978 when I first served a nursing home. In some states, half of the nursing home population was tied to their beds every day. There was a nursing home in Washington, D.C., where I worked at the time, that had half of the residents having stage 3 or 4 pressure ulcers from being tied down to the bed rails. Now, those weren't evil people. Those were people trying hard to do a decent job and not knowing what a good job would look like. We have come a long way. We have come a long way since 78. We stand to lose it all if we do not deal with the financing of long-term care. So here's what I've been working on for the last couple of years. The WISH Act. Tom Suozzi is a congressman who is leaving the Congress, but he had the guts to at least put it in the hopper. So why federal? Because if you do it at the state level, you have enormous problems with people moving around. People work across state lines, but in both directions, live in one state, work in the other, live in the latter state and work in the first, and they move. I've lived in New Hampshire, Virginia, Maryland, DC, and now Massachusetts. Where would my state long-term care be? So it has to be federal. Why only catastrophic? Because if there were federal coverage for catastrophic levels of long-term care, then people could make plans to cover the upfront costs, the ordinary costs, the people who live for a year with severe disability, or have a stroke and live 6 months, or have a stroke and live 2 years. But 1 in 7 of us will live more than 5 years with serious disability at the HIPAA range, which is cognitive failure requiring constant attendance or 2 or more ADLs. If you had the catastrophic level mostly covered, then you could make plans to cover the front end. You could have 5 kids who love you dearly and will take care of you. You could save enough money, or you could buy long-term care insurance, which would then be quite affordable and flexible, because right now, most of us can't buy it because we have some chronic condition. And if we could buy it, it'll be limited to something like 1 to 2 years. What level of disability? Well, let's just use the HIPAA standard, that 2 ADLs or more, or cognitive failure requiring constant attendance. Why social insurance? Because then everybody owns it, just like Social Security. There are challenges in the ramp-up period. Everybody I've talked to, and I have personally talked to more than 300 people about this, everybody who doesn't just get hives whenever I say tax says, yeah, this is what we should have done back in 1980. And they're right. If we had done it in 1980, we would have already endured the ramp up. At the present time, if you do social insurance today, you have to deal with a huge number of people who are already retired or who are right on the cusp of retiring. And how do you cover them? So we have to deal with the ramp up. So what the WISH Act proposes is a targeted supplement to Social Security, providing income at the time when you need it most. So what is catastrophic relates to your income history. So the bottom 40 percentile of income would wait only 1 year. Now 20% are already on Medicaid, so they effectively are already covered. Then for every 1.25 percentiles of a higher lifetime income, you extend the waiting period by a month. So a person whose income is in the 70th percentile will wait 3 years, and the really rich will wait 5 years. Now this particular resolution could be modified, of course, but this is the kind of way to think about how to do catastrophic long-term care insurance. And the way we've proposed to finance it, and again, this could be done in other ways, federal government would collect insurance of roughly 0.6% of wages. That means if you make $100,000 a year, your employer will pay $300 and you will pay $300. That is sufficient to finance the system. And then the private insurance market will be regenerated because now you can actually make plans for long-term care. So let me just walk you through a couple of ways this works. So a person who made $80,000 per year, adjusted of course to the current year, and later needs 10 years of long-term care, needs a lot more long-term care than most people. So here, during their working years, they're making their insurance contributions. Then they're retired but don't need long-term care. And then they get a long-term care need. And this part is covered by private insurance because this person has a 2-year wait, actually a 3-year wait. And then the long-term care is needed and covered by the WISH Act. On the other hand, a person who makes only $30,000 per year and needs 4 years of long-term care, again, more than most people will need, goes the same sort of way, but when they encounter the need for long-term care, it'll be covered by Medicaid, and then WISH will kick in as well. So this is the way that the WISH Act would work. Beneficiaries will be older adults with ADL dependencies or cognitive failure, older than full retirement age, and finished a waiting period. They'll get a monthly check of $3,600, adjusted for wages and inflation each year. This is enough to pay for about 6 hours of direct care per day, which does accommodate most people needing long-term care, assuming they have some supervision, if they have cognitive failure, from family or friends. Full benefits will go to people who contributed for 10 years, and then prorated benefits for people who worked for at least 5 quarters, which is just over a year. And then it'll spread the risk across everybody. It will fund the Long-Term Care Insurance Trust Fund. We have written this to be terribly conservative. It is written as if it were a private insurance fund. That could be modified as it goes through the legislative process so that it is not just that each cohort is really paying for itself. For employed workers, it'll be split. For self-employed, they will have to pay the full amount. And then we've allowed the trust fund to invest in low-risk securities, not just in federal bonds, because if you're waiting 60 years for payout, you're guaranteed to have lost a lot of value. So what next? Well, fear of disability in old age is becoming the major concern. We did a survey back at the 2016 election, and the Carter voters and the Trump voters all ranked this very high and similarly. And they were concerned about the availability of caregiving. At the present time, a person trying to be responsible has no way to protect themselves and their families because you can't afford long-term care insurance and it's capped. Federal catastrophic long-term care insurance would address these challenges. It has been endorsed by including the American College of Physicians, which has just signed on, the National Academy of Medicine, Geriatric Society, the Committee for a Responsible Federal Budget, and so forth. Virtually everyone agrees that WISH is good policy and should have been enacted some time ago. What is missing? What is missing is the will to do anything, and I mean anything, about long-term care and its financing. It is not being polled in the midterm elections. It is not being asked of political candidates. Everybody wants to pretend that somehow this will go away. The WISH Act will make private insurance affordable, predictable. It will allow working people to make plans. Benefits are all of these things. You'll be able to age at home much more often. You'll run out of money much less often. You can make plans. You can protect the ranch. You can protect the business. You can protect the kids. The government will not need to be investigating personal matters by having you have to go through a whole lot of proof of your financial issues or who will take care of you. Elders will much less often face homelessness or being hungry. Workers won't be forced to leave their jobs. Americans will know the likely need for long-term care later in life because they'll be paying taxes and getting information as to when they're qualified and roughly what their weight will be. Medicaid costs will be reduced by a quarter or more, both state and federal. There is no way that most states are going to be able to double their long-term care Medicaid expenditures. Nursing homes and other providers of long-term care will be better funded. The pressure to increase hospital and nursing home capacity will be reduced, and the personal service workforce will be better funded and presumably provide better care. But the downsides, no one likes taxes, and no one likes to talk about long-term care. It requires a certain amount of monitoring, a system for appeals, some records, some managing of fraud and abuse. We've put all of these things into the bill. What else could you do to expand the dollars to long-term care? You could expand Medicare a little, but not a lot. To include all of long-term care, as Bernie Sanders' bill would do, would more than double the cost of Medicare. You could expand Medicaid, yeah, some, but you're still going to have to spend down to it. And you could really only do it where now it's very limited because state budgets won't tolerate it otherwise. You could expand space and special needs plans. I agree. I think we should have PACE everywhere, and special needs plans should be widely available. What blocks PACE from being expanded is a ridiculous misinterpretation of the interface between the PACE statute and Part D. So the usual person who has Medicare only and tries to go into PACE will have their apparent cost of Part D go from $45 a month to over $1,000 a month. You can't convince people to do that. That could be reinterpreted so that people could stay on their $45 a month plan, but the CMS has not been able to do that yet. So basically, PACE is available only to dual eligibles or dual enrolled. SNP, yes, you can get into SNP, but they're very limited. It's either an institutional SNP or a chronic disease SNP or whatever. And some of them are very good and some of them are not. So we could work on that. We could expand private long-term care insurance, sure, but not in the present arrangement because the long-term care insurance companies won't take the long-term risk. You could manage at the community level, yes, but we have to actually learn how to do that. So right now, the most appealing thing is federal catastrophic long-term care insurance, something like the WISH Act. So why aren't we doing it? Well, we need to raise awareness. I call that generating outrage. We need to talk to politicians, and it's we who need to do it. Yeah, we think it's enough to get the right drugs to people, to do the right diagnoses, to be sensitive to families. We need for the first time in a long time, to be the people who push our politicians. We need to tell the press stories about what happens to our people. We need to write to newspapers. We need to engage with Twitter. We need to get information into public education. The My Medicare book needs to be honest about what you face. We need to focus attention on Social Security, long-term care costs, and the burdens on families. We need to get organizations to weigh in. Every organization you touch needs to be pushing for there to be a plan for the financing of long-term care. And of course, the long-term care insurance companies are the only entities around that have the reserves to push the politicians. It's not going to be pharma. It's not going to be the big medical care providers. You look around and say, who has the money? And it's only the long-term care insurance companies. Who has the votes is the public. So we have to get the the two things that move politicians, votes and money, and they're roughly correlated. So you have to get votes and money pushing on this. Here's how we're mostly dealing with long-term care. Head in the sand. The public and the politicians. We're all pretending that somehow this will go away. Your congressional representatives should be very interested. Now, I've only done the ones from right around your place, but anybody from elsewhere can get your representatives and your senators. Your senators will probably be roughly the same, but you can get that in about 5 minutes on Google. You can find out which committees they serve. If they're in the House, they need to be on Ways and Means or Energy and Commerce. Your representative, Neil Dunn, is on Energy and Commerce. He ought to be a sponsor of the WISH Act. You ought to push him every place he goes. You ought to get your patients, you ought to get your staff to go to town hall meetings, to send emails. Representative Al Lawson has lots of useful elements in his history of legislation. He's not on either of the key committees, but he could certainly weigh in. Rubio in the Senate is on Appropriations and the Select Committee on Aging, and Scott is on Budget and the Select Committee on Aging. Those are the two key committees. There's actually also Finance Committee. So, but they're both on the Select Committee on Aging. So they should be pushing for hearings. They should be enrolling a WISH Act in the Senate side. This is very much a bipartisan bill. I know no one in Washington seems to be able to actually function bipartisanly these days, but this one is very much bipartisan. The bill we've put together has been endorsed by the Committee for a Responsible Federal Budget, one of the most conservative elements in DC, because it is structured to pay for itself and it's honest about the costs. So you can have what you want and need when you're old and frail, but only if we go about delivering that future. Many of us may have been able to save enough to probably get through. Some of us may have had 4 or 5 kids who love us dearly, but most of our patients and most of our future patients are in a terrible spot because they will not be able to afford the basics of life. Just staying clean, under a good roof, with food, in a situation in which you're respected, you're cherished, you're helped to live with purpose and comfort. We've got to push for that. We've got to start making it a public issue. So your questions, your thoughts, your plan of action. I'm going to put on the screen a set of resources, but you can also get these on my website. And on my website is just Dr. Joanne Lynn at drjoannelynn.org or medicaring.org. And they have different things, but you can go to either one and you'll see them in the list here. So fire away with comments and questions.
Thank you so much, Dr. Lynn. We're going to begin answering the questions that were submitted during your presentation. As a reminder, you can still submit your questions by typing them into the questions pane in your attendee control panel, or if you're in the live classroom, go ahead and raise your hand. Dr. Lynn, your first question is, could county health departments and area agencies on aging be transformed to help build geographic health authorities?
Oh, now that's a favorite question of mine. Yes, area agencies on aging and county health departments and nonprofit hospitals each have a mandate to assess the needs in their community. And in the past, those have been pretty much pro forma. They measure whether people are getting flu shots and things like that. We could really push them to get serious about long-term care. We could really get them focused on that. We could get them to do it together so there's enough resources to seriously assess what it is that people most need. The only part of the Medicare system that is geographic is PACE. So if you have a PACE program in the area, you could pull PACE into it. But everything else is non-geographic. And so we have to actually develop the coalitions and the governance that would allow you to do, for example, citywide or countywide data collection on what the priorities are and how to go about fixing them, and then monitoring whether the fixes are actually working. Exactly.
Perfect, thank you. Do we have any questions in the room?
Yes, we have a question. Hold on.
Thank you so much for that excellent presentation, Dr. Lin. This is Tatiana Shippey. I presented earlier today. I have looked a little bit at this issue myself, and I found that in national surveys, just as you've shared, most older adults don't know how much long-term care costs and don't know how they'll pay for it. But also, this issue is not, or this burden is not equally distributed. So for example, you talked about people having kids. We know that sexual and gender minorities of this cohort are much less likely to have children. And so this was actually the group that I published in my work that expected to need formal long-term care more than any other group. So I think this is an important issue too. So I guess I have two questions for you. First question is, could you talk a little bit about how this proposed policy would potentially integrate differential needs? We talked about ability to pay, but how could this work for people where maybe they have a better expectation? There are some groups they know they will need formal long-term care and maybe are planning in different ways. And then the second question is, I teach a course on multidisciplinary perspectives on aging. And this last year, we've talked about the Washington State's CARES Act that funds long-term care insurance. And so could you talk a little bit about, you critiqued state efforts and you talked about the need for federal policy. Could you talk a little bit about what Washington has done and how that fits with your proposed bill? Thank you.
Now, with the data that you could now readily make available, you could, let's say for a county, for Broward County, you could know whether any serious problem in old age is affecting racial minorities. You could know whether it's affecting a particular geographic part of your county. It's harder to get to the gender minorities because our databases don't actually catalog that. But local knowledge probably could turn that up pretty quickly. You could have the public health office do death certificate followbacks of just a sampling of people who died and asking of their caregivers, what went well, what went badly, and pretty quickly get at least newspaper level of data to guide the priorities. So you really could integrate the different needs of different segments of the population with the data we have now, and we could also improve on that data. Obviously, if the three entities that were mentioned just now all went together for assessing the needs in their community, you could do a survey. A survey was done in Fargo, North Dakota, and Moorhead, Minnesota, by the North Dakota State University, funded by the medical care system as part of their community health needs assessment. And overwhelmingly, the public pointed to long-term care needs as the thing that they were most concerned about. Incredibly, the healthcare system said, oh, it's good to know that. We'll send it on to the United Way. No, wait a minute. The medical care system has to be part of the solution. It is not somebody else's problem if your patients have no roof. It is your problem. It is our problem. It is a community problem. And we all need to pitch in. On Washington State, just to shift to your second question, it is not at all clear that that will ever quite make it into being implemented. I hope it does, but they made some really big mistakes. There are a lot of people who live in Idaho or Oregon and work in Washington, and a lot of people who live in Washington and work in those other states. And there are a lot of people who expect that they might well move in retirement or even move during their working life, none of whom were considered in the legislation. It also only covers the first $35,000 of expenses in long-term care, which is not the prudent direction. It is the direction that is easier to garner votes. But the first $35,000, many people could have saved for or bought insurance for over their working life. It's the people who have 4 years or 5 years of long-term care that really breaks the bank. So catastrophic is a better public social insurance, and it would be better for people to go together and get social insurance for the back end, for the catastrophic level, rather than to try to cover the front end. You know, $35,000 if you need nursing home level of care is gone in just a couple of months. So, you know, it would be better to be honest about what you're actually getting.
Dr. Lynn, you mentioned there, U.S. is probably the only country that doesn't have a good system of monitoring illness, disability, expenses, et cetera, on a geographic level. Is there a country or countries that are actually doing this right that we can learn from?
There are countries that are doing every fragment of it much better than we are. There's no country that's pulled it all together that I know of, at least. There are very interesting arrangements. The home care, for example, in the Scandinavian countries is entirely geographic. So in Washington, D.C., we have 60 home care agencies, each of which has to serve every piece of the city. So because every agency has a 3.5-hour minimum, you end up, for somebody who needed 45 minutes of services in the morning and evening, paying for 7 hours worth. If we had geographic provision, then 2 or 3 aides would be in an apartment building and they'd move around, and you'd be able to pay them twice as much and still save money. In Germany, people who don't have children pay a higher tax than people who do, and the children are obliged to help out in taking care of their parents, even if they didn't like them. So there are many different ways of organizing things. Japan has lots of robots and also a real tradition of not quite elderly people taking care of the elderly kind of in sequence. So the 60-year-olds take care of the 85-year-olds, and then when they're 85, the next generation of 60-year-olds is recruited. So everybody has some different arrangements. In Canada, right across our border, they have long-term care folded into the public health service. There is right now a coalition underway that is trying to deliberately learn from one another to accelerate the pace of change. What we are missing is any entity that actually takes responsibility for the life lived by elderly people living with disabilities. The hospital doesn't do it. The AAA is not funded well enough to do it. The public health office traditionally has not been concerned. we have it all broken up, and we somehow magically believe that this crazy quilt will somehow not leave gaps. And yet every family you talk to, even if they are wealthy, sees gaps. They have problems. They can't find the right services. They don't have a workforce. They can't at any price find somebody who can take care of their mother. So, we are behind because we don't have any entity that actually takes responsibility. Other countries at least have that.
Thank you. Clara, are there additional questions?
I do have another question, yes. Our next question for you, is there any way around having to go through political figures to make these changes more quickly? If you had a magic wand and politics weren't an issue, how would you get these changes happening?
Well, the magic wand would have to be able to change statute and regulation. So, for example, CMS has recently put out a model that allows very wealthy companies to essentially buy the opportunity to serve geographic areas. And one of their requirements was that there be at least 2 and preferably 3 such entities in every area. Fine for competition, okay, but when you're homebound, geographic provision of the services is so much more reasonable. The Veterans Administration is doing a much better job than the rest of us in providing for people living at home with serious disabilities. But every time a veteran's home-based primary care team goes out to see a veteran, they are driving past 10 or 12 people who needed the same services. This is costly. Instead, we should be able to take care of the veterans and anybody else who needs caregiver support, who needs help with how to manage the technology, who needs the workforce to help with bed baths and keeping a person clean. We need to be able to have housing. We need to be able to talk to the zoning people and the housing people. Right now, in every area where I've lived, everybody wants to build a suburban house with 3 or 4 bedrooms. We need senior housing that's all on one floor and has 1 bedroom. And nobody wants to build that. We need incentives to get people building those sorts of places so that our seniors have a place to live. There is a lot to be done. A lot could be done locally, but you will run up against the problem that Medicare pays doctors and hospitals, and the social services are funded essentially by crisis. So in a county next to Washington, D.C., I was working on county-wide improvement under the Accountable Care Initiative that CMS put out. And we found that every social service for the elderly had a waiting list longer than a year, some of them a waiting list 5 years long, which is longer than the average survival of the people on the waiting list. If it takes 6 months or a year to get home delivered food, people are in a very difficult situation. And yet the funding for home delivered food, for Meals on Wheels, the funding for protection from abuse, the funding for housing, have all been allowed to languish. So Medicare is a right, and we can run up whatever bills we please. Well, I mean, as long as it isn't fraudulent. But no one says anything about my relative getting $20,000 pill or infusion every month at 96 with multiple disabilities and 2 cancers. I'm sure if offered, his family would prefer $10,000 a month to help pay for the home care. But no one is in a position to ask for that because we've set up Medicare as a right and everything else as a welfare. And, we just don't afford to pay for it. On average, other countries spend twice as much on supportive services as the United States does and spend half as much on medical care. So the origin of people not being able to get the services they need is easy to trace. And eventually you do have to deal with the Congress. You can do a lot locally. You can argue for better housing, and you can work on local funding for Meals on Wheels. But in the long run, we must change the rules at the federal level.
Joanne, I have 2 questions. One is, how do you sleep at night, knowing all this? The second, more serious one is if I'm interpreting what you just presented, having the WISH Act implemented would actually put a lot more money into long-term care. Where do the provider associations like Leading Age and ACA, where do they stand on this issue?
Well, those two have endorsed. American College of Physicians wrote a position paper that is marvelous. You should see it. It's open access on the web. It's in Annals of Internal Medicine this month. But that is a tremendous précis of what we face in long-term care. But they endorsed catastrophic long-term care, and now just this week they have endorsed the act itself. There are not very many groups that have turned it down. There are lots that are waiting in the wings with their heads in the sand, saying to me, yes, this is really good. This is really what we should be doing, but I'm not going to do it until there's a movement in this direction. I'm not going to kind of, put my efforts into this rather than, and everybody's got a first. Everybody says, but first we need to do X. But first we need to improve the pay and benefits for home care workers or for nursing home workers, or we need smaller nursing homes, or whatever it is that's their axe to grind. And I have become a robot in saying, can't we do a first and a second? Yes, of course, fight for those things in the short term. And we are going to lose them all if we don't improve the financing. And for that matter, the financing and the organization. We need to know the priorities in a geographic area and have a way to improve them. And, as was said very well earlier, we need to be able to see that some populations are not getting what they need. In long-term care, no population actually gets what they need. That's a hard truth. At least the very poor get Medicaid. The people just above Medicaid are in the worst possible shape. They just lose everything. The very well-off can at least afford things, but the things aren't there. Jay Rockefeller used to give a talk about how when his mother had dementia, that it didn't matter how much money he threw at the problem. If there weren't people trained to do home care for dementia, it didn't matter how much money he had. If there weren't people there willing to do this work, then he couldn't hire them. And so we need to really work on the workforce issues. We need to work on the housing issues. We need to work on the food delivery. We need to work on the family caregivers, making industry be willing to be flexible about people's time. There are a dozen things we need to work on, and they all fail if we don't change how the care is organized and the money that goes into it. By the middle to late 2030s, the crisis will have arisen. Dornbrand's law will have shown once more. Instead of it coming in 2030, it'll come in 2035 or 6, and we will learn to let 90-year-old disabled people be on the street. We've learned to turn our heads to 45-year-old schizophrenic men. We will have to learn to turn our heads and not notice that mechanics and bus drivers and home health aides and so forth in their 90s don't have a housing. That would be a really, really awful thing for this country to tolerate. So we will probably go into deeper debt rather than having begun to deal with it now. It is so hard to get anyone in the United States to think 10 years out, to realize that we actually face a serious problem 10 years out. People are concerned about the midterms, maybe the presidential election, maybe what they're paid this year. Boy, getting people to think 10 years out is just really tough. And to seriously deal with long-term care is just really an uphill battle. People want to think that they will somehow evaporate in old age, that they will somehow just not have this experience. Even people in leadership positions think that somehow they are insulated from it. They'll just die in their sleep at 92. Good luck with that. Good luck with that. The ways we have to die now are all with chronic conditions. Yes, every once in a while someone has a terrible stroke and dies in 2 days. Every once in a while someone has a cardiac arrhythmia and was playing golf yesterday. And now for the other 95% of us, we need serious planning. This didn't exist in 1965 when Medicare passed. When Medicare passed, the average age of death was still 68. The usual causes of death were pneumonia, strokes, and heart attacks. We did not have much dementia. We did not have much Parkinson's. We did not have much serious disability from strokes because people didn't live and because medical care didn't think they could do anything. I mean, I remember when I was in training in the 70s, surgeons didn't think they could operate on people in their 90s. How many people in their 90s had surgery in your area this week? You know, so we've changed the demographics. We've changed the way people live in their last years, and we have not changed how we pay for it or how we organize it. And it's high time we do so. And everybody here needs to really push. I know you're busy. I know you're overwhelmed, but it doesn't take much to call your congressman. You could take 10 minutes and call your congressman's office and just ask, what is your policy on long-term care and why aren't you on the WISH Act? And they won't have the least idea what you're talking about. But by the 6th or 8th person who calls, they'll have an answer. And by the 20th person, they'll even have a good answer. We have to get it started.
Joanne, thank you so much for an incredible presentation. I think, and the advocacy, obviously your website, et cetera, has all the information needed when we do advocate our local representatives. So thank you again. I think we're at the time. So I'm gonna go to our next presentation, which does relate, I think, in large part to what Dr. Lin has been talking about. The National Academy report on improving nursing home care comes with a cost. It's just a very small piece of what we're talking about. We're very grateful to have 3 leaders in the field commenting on this report. I'm going to introduce our first speaker, who will give us an overview, Dr. Philip Sloan. Dr. Sloan is the Goodwin Distinguished Professor of Family Medicine and Geriatric Medicine at the University of North Carolina, Chapel Hill, where he co-directs the program on aging, disability, and long-term care of the Cecil Sheps Center for Health Services Research. His clinical work has included serving as medical director of a skilled nursing facility, founding medical director of a dementia unit, director of a nursing home teaching service, and attending physician and quality improvement consultant to a PACE program. His research areas are varied. They include assisted living, nursing home care, infection management, behavioral symptoms in persons with Alzheimer's. He is a recipient of the Pioneer Award from the Alzheimer's Association and an Academic Leadership Award from the National Institute on Aging. And he was a member of the National Academy's Task Force on Nursing Home Quality, which he is going to help us sort through. He is also, as many of you are aware, and I've had the good fortune of working with Phil over the last 5 years in his capacity as co-editor in chief of JAMDA, the Journal of Post-Acute and Long-Term Care Medicine. So Phil, we'll give you the floor. Thank you very much.
Hi, Paul, and everyone else here. Pleased to be here, happy to talk. And of course, I'm not just the only one who's going to be talking about the National Academy's report. All 3 of us will. And Joanne, thank you for that inspirational talk. It's hard to be optimistic. At least, I always kept in mind, what Winston Churchill said. He said, "The Americans will always do the right thing after exhausting all the alternatives." but we just seem to get deeper and deeper into the alternatives, and I just don't see the right thing emerging from kind of our political and social will. But that's an aside. We're going to talk about this National Academy's report, and first of all, I need to talk about why am I not able to forward this?
Just move your mouse on the presentation and click on it, and then you should be able to advance.
Okay. Nope. There we go. Okay. Well, we were all trained in this, but that was like a week ago. So the National Academy is interesting. You know how Facebook is renaming itself as Meta, and then there's all this stuff about it. Well, the National Academies used to be known as the Institute of Medicine. And so most of us still think Institute of Medicine, but they renamed themselves because they deal with other things than medicine, engineering, other sciences, and they're essentially a nonpartisan, non-governmental think tank that Congress and the executive branch will listen to, at least to some extent. And they were basically set up by Congress. So anyway, in 1986, they had a report on nursing home care, which led to OBRT 1987, which was certainly the biggest piece of legislation. There hasn't been anything like that since then. There have been some tweaks and changes, and that Nursing Home Reform Act, they felt that after COVID and what had happened, that maybe it was time to relook at nursing homes and examine how the U.S. delivers, finances, measures, and regulates the quality of nursing home care. They made recommendations for regulators and policymakers, and I want to emphasize right at the beginning, the National Academies and the group believes that all the recommendations that they made have to be considered as a whole, and you can't just do one thing and expect the system to change. The process involved information sessions with leaders of provider, regulatory, and resident advocacy communities. It was something like 35, 37 different sessions. We had very extensive literature review. The Academy's task force did a terrific job, and then had a large, moderately large committee of experts from nursing, medicine, and policy that guide the process and synthesis. Which I have to put this up here because a panel of experts does not necessarily solve problems. It can often come up with ideas, but the problem solutions, I think, as Joanne was mentioning, have to come more to grassroots level. When you're starving, you do not want a panel of experts because you end up with something like this, which is our conceptual model of quality of care in nursing homes. If I tried to explain this, it would take up the entire hour, other than just to point out that it's complicated. The whole system is complicated, and we would like to believe that the resident is the center of the whole focus of the whole system. But when you look at the different entities engaged in it, it doesn't always seem that the resident seems to be at the center. So I'm going to talk about, before getting into the report, I'm going to editorialize just a little bit and talk about some of the issues that were not addressed in the report. And the first one, frankly, I don't even have, we never, Joanne said, what do people, what's it going to be like in 10 years? Who's thinking about 10 years? We were not thinking about 10 years. The National Academies group did not, we just did not have that discussion. What are nursing homes going to look like in 10 years? With all this movement toward community-based long-term care, care at the home, assisted living, all these other things that have arisen since 1986. You could really say it was a bit myopic to just look at nursing homes. On the other hand, the reason they did it is because they didn't want to get too, they didn't want the work to be so vague that it will cover so much, and The other thing is because nursing homes are regulated by the federal government, whereas assisted living, which is the next thing we want to look at, is mainly regulated by the states. So we didn't want to deal with the fact that we've got a complex system that doesn't have a single focus. We also didn't talk about post-acute care and whether nursing homes have this whole game that they play because Medicare pays better than Medicaid, and so they buy for post-acute patients. But in fact, if you think about it, somebody who wants to go home has very different needs and very different settings and very different environment created than somebody for whom it's supposed to be a home. And it's something we just could never come to a consensus about, so we didn't talk about. Didn't actually talk about the role of the states in nursing home quality, and there's quite a bit of state variation. And so that's a whole other issue we just couldn't talk about. It was just too much. And this is a personal thing. We didn't come up with recommendations about professionalizing the nursing assistant role. You're going from 75 hours to 125 hours does not turn nursing assistants into a profession that really understands, can take care of, and deal with the complexity of medical issues and functional issues that are present in the nursing home population, particularly the future nursing home population, which I think is going to be primarily people who need pretty much total care or have very advanced dementia. And that's different than a lot of people still think it's going to be in the future. We didn't talk about immigration as a possible source of manpower. It's kind of a nasty thing to talk about politically, but Italy, which has one of the oldest populations in the world, has for a long time taken immigrants from Latin America. Japan takes immigrants from Southeast Asia and to bolster up their long-term care manpower. We didn't talk about that. And then finally, we didn't really, we did the best we could to deal with the fact that political realities are there by not being too ambitious, sort of kind of like Dr. Lin was. Well, let's just go for the WISH Act because that's something we might be able to get past. But there are just so many realities, one of which is that the decision made in 1965 that Medicare was only going to cover hospital and post-hospital care and long-term care was not going to be on Medicare. That's really the basic flaw in our system, was to ignore long-term care from the beginning. And so now where we're at. So the report had a number of goals. I'm going to just talk briefly about one goal, which is to deliver a comprehensive, person-centered, equitable care that ensures residents' health, quality of life, and safety, promotes autonomy, and manages risks. Now, if you want an illustration of something that was developed by a committee, I would say that recommendation fits that bill. But when we dig into it, it really mostly says, just do what we told you to do in 1986. Just implement OBRA 87. It really talks about doing person-centered care, assessing residents, treating residents individually, promoting autonomy. Most of these things are already in the legislation. And so I was kind of, not, well, I'm getting ahead of myself. Here are the key recommendations. Number one, comply with current regulations regarding provision of person-centered care. Number two, more research regarding most effective care delivery methods. Well, that doesn't really help anything in the present. And then more specific inclusion of nursing home residents in state and federal emergency disaster planning. This goes without saying, after COVID, this was going to come in, but that's already kind of in the works. I don't see, with my cynical lens, there's not much novelty here. This is the only thing I thought got a little bit out of the box of 1987, which is building on the small home model, the greenhouse model, and advising construction and renovation of nursing homes to provide smaller, more home-like environments, including private bedrooms and bathrooms. And there's just so much evidence that shows that not only does it make people happier, it also is great for infection control. So, and that there is this improved Nursing Home Act that's been introduced in Congress specifically to provide some resources and incentives for nursing homes to do this, because so many nursing homes are old buildings, and they could benefit from some serious revision. So I know we're going to hear about from our other presenters, and so I'm ready to turn it over to them, but I do have a final conclusion that may be premature, but I would propose that we will not succeed in resolving all our problems, but we will raise a new set of questions and in some ways be as confused as ever, but at higher levels and more important things. So that's what happens in these conferences. I guess I'm getting too old to not be honest, but we've got a real challenge here with the long-term care system, and it's not just nursing homes, but now we're just talking about nursing homes here. I think, Laura, you're going to go next?
Yeah. Yes.
Yeah. Thank you, Dr. Sloan. And what we're going to do is hear all three presenters, and then we'll open it up to questions. Our next presenter, Dr. Laura Wagner, we've already been introduced to. Dr. Wagner, as you know, is professor at the University of California, San Francisco School of Nursing. And Laura is going to, I think, continue discussing the report as it relates to staffing and person-centered care. So, Laura.
Hi, good to see everyone again. So I'm going to talk about two goals today that are in the report. The first one I spoke about earlier, some of the content from it regarding goal 2, which is to ensure a well-prepared, empowered, and appropriate compensated workforce. In the interest of not having you read the 600-page report, which Philip neglected to say that this is a 600-page report, I have 24 slides here, but I'm not going to say everything in the slides, but I wanted to pull out the key essential information for you in case you want to refer to it someday, so you don't have to go and sift through the 600 pages. So first of all, I don't need to go into too much detail as I talked about all of these staff earlier. We have a number of staff that work in nursing homes. They constitute 1.2 million workers in the nursing home setting. So I've listed those out here. I'm sure there's more. And I didn't want to exclude families and volunteers regarding that. So the recommendations, one of the recommendations around staffing is to ensure competitive wages and benefits, which we spoke about earlier. The importance of having that and the importance of making sure that we're competitive with other sectors in healthcare. The next recommendation is around CMS and ensuring minimum staffing requirements, direct on-site RN coverage, a full-time social worker, which has not been explicated in the past, and then also an infection prevention and control specialist. There was some discussion prior to COVID about this moving forward, and then COVID just hit, and we were able to see the impacts of not having that level of dedication at the facilities. There we go. Another recommendation within this goal is to fund research to identify and rigorously test specific minimum and optimum staffing standards for direct care staff. And as I said, currently CMS is working on putting this together with a group of researchers. The next recommendation is around enhancing available expertise within a nursing home. So having the current administration consult with licensed clinical social workers at the MSW or PhD level, or even other types of advanced practice providers. Also providing incentives for nursing homes to hire these individuals, including allowing Medicare billing and reimbursement for these services, which is currently minimal. Next, as Philip alluded to earlier, we want to advance the role and empower the CNA as he talked about professionalizing this role. We need to do a tremendous amount of work in this area, especially since the CNA is the largest workforce within nursing homes. Next, talking about minimum education and national competency requirements. This one's a real struggle, just given our pipeline issues that we have in the various programs. So for nursing home administrator, a minimum of a bachelor's degree. For medical director, completion of an education or certification program. director of nursing, minimum of a bachelor's degree in nursing, director of social service, minimum of a bachelor's degree, and also certified nursing assistants, as Philip alluded to, increasing the number of hours, but that still doesn't do enough. Also, another recommendation is providing flexible, low cost, and high quality pathways for these individuals to achieve these baseline education and competency levels. I think there's a number of model programs out there at the state level that are trying to enhance the role of the CNA. I know of some work going on here in California in order to do that. And I think identifying where these models of excellence exist and capitalizing on them and trying to get states to fund them is important. Also, you know, looking at the content that we as academics provide in our clinical training programs. This is not old news. We've been talking about this since really the Teaching Nursing Home report came out in the early 90s, that students need to have gerontology content, assessment, long-term care experiences, palliative care experiences, and clinical experiences in the nursing home. Also, enhancing the education, including annual continuing education training requirements. And then something that's been an ongoing thread of discussion through this entire conference is around diversity and inclusion training, around just making sure that workers and leadership ensure that we understand who we're working with, who we're caring for, and that we can have cultural humility around these individuals. Also, working with family caregivers to ensure that the family is included as part of the care team. And then collecting information, that was another part of the report around recommendations for research purposes and for CMS to report data. So demographic information about the workforce, the types of training the workforce is receiving, and then again, numbers and staffing patterns that we spoke about earlier. And then funding research on systemic barriers and opportunities to improve recruitment. As I mentioned earlier about wages being a particular issue among getting high quality staff, turnover, job satisfaction, practice environment. You know, how can we improve the work culture within nursing homes? So the priorities in this area that I see are really looking at how can we enhance our currently probably non-existent anti-racism initiatives around hiring practices. How can we teach both staff and residents and families about racism and discrimination? I'm currently doing some of this work with my dementia care training. You know, teaching staff, how do you deal with the fact when a resident is racist to you and they have dementia? Like, how do you support the staff member in a better way? So we're currently doing some work on that with my R01 research funding. And then a concept called restorative justice circles, where there can be healing when events do happen within the work site. Consistent assignment, my colleague Nicholas Castle has done some research on this in the past, the importance of staff having a consistent assignment for both the residents' sake and for the staff's sake. And then also this concept of creating a dementia capable workforce. And I alluded to PHI International recently in my other talk. They've presented a report recently on their website. You can download it. Talking about how can we further enhance the workforce to better care for people living with dementia. The second goal I'm going to talk about today is around adopting health information technologies in nursing homes. So there's a number of HIT in nursing homes. I'm not going to go into each of these, but just a lot of technology. And I'm sure those of you who've been in the industry long enough know that this has dramatically increased in the past decade. So what are the benefits? You know, we have a lot of benefits around efficiency, payments, triggers, care, enhancing care planning, and quality improvement. And as I talked about earlier, telehealth opportunities. Sorry, having a delay in the challenges include finances. There was an act in 2009 called the HITECH Act. This act excluded nursing homes from receiving funding to enhance technology. Now were giving monies to hospitals and primary care settings instead. So that's one challenge. We also have an issue with interoperability where systems do not communicate with each other. So we buy one piece of software and it can't communicate with the other piece of software. We also have this lack of the health systems integration. So we have a resident in a nursing home, which is in one system, going to a hospital, which is in another system, and the systems don't communicate with their electronic health record. And then we have a number of facility barriers, including training, tech support, Wi-Fi and connectivity, outages within Wi-Fi, or you're down the hallway and the Wi-Fi doesn't work that far down the hallway. Slowed workflow at first when there's ramping up of procedures, and then also a number of workarounds that occur. So the recommendations really focused on how can we enhance and increase the use of technology in nursing homes. So these are providing incentives modeled after the high-tech initiatives, promoting interoperability to minimize interoperability, and also adopting this health information exchange between healthcare systems. Also around developing measures for HIT adoption, we found in our research, it takes about 5 years for a facility to become fully integrated with health information technology. So it's not an overnight process. And so if we are better able to measure that process and see the length of time and the challenges that are faced, then that would be important for us to know so that we can go to Congress. Also, financial support for the development and ongoing implementation of training. This is often left up to the facilities. Funding rigorous evaluation studies to explore the impact that technology has on the efficiency of care, the improvement in resident outcomes, looking at disparities across nursing homes, which types of facilities are better equipped to implement HIT versus those that are not. So where do we start? And we'll have our questions at the end. Thank you.
Thank you, Laura. And now we'll switch to Dr. Michael Wasserman. Dr. Wasserman is a well-known geriatrician who has devoted his career to serving the needs of older adults. He's been a tireless advocate for vulnerable older adults, particularly during the COVID pandemic, and has been on the media with multiple quotes, publications, and television appearances. He served as a member of the National Academy of Sciences, a framework for equitable allocation of vaccine for the novel coronavirus committee, and was a member of California's Community Vaccine Advisory Committee. He presently serves on the Infrastructure Work Group for the National Advisory Committee on Seniors and Disasters. He's editor-in-chief of Springer's upcoming textbook, Geriatric Medicine, a person-centered evidence-based approach. Interestingly, Dr. Wasserman previously served as a chief executive officer overseeing the largest nursing home chain in California, which has given him unique perspectives. Most importantly, Mike believes in the importance of exercise as we age. He's completed 16 Ironmans since 2010 and routinely runs 30 to 40 miles a week. He's just showing off now, while also biking and swimming. You can do that in California, I suppose. So, Mike, it is a pleasure to have you here, and we look forward to your review.
Thank you. So, I'm going to take a slightly different tack. I'm going to talk about goal 3, which is transparency and accountability, and allude to goals 5 and 6 that have to do with quality assurance and continuous quality improvement. But I'm taking a little more high-level approach rather than go through the recommendations, because I think it's really important, especially as it relates to transparency, to help folks, especially in the clinical realm, understand why we're looking at transparency. And we'll all notice that none of us are talking about goal 4, which is financing of long-term care. And I actually think that until you address transparency and accountability, you really have no business talking about financing. So we'll come to that and help people hopefully gain some greater understanding. So one of my favorite things to share is back in the summer of 2018, as was said, I was running a 74 facility nursing home chain, and I got in my car and visited all 74 facilities over the course of 6 weeks. I'm not sure any CEO of a large nursing home chain has ever done that. I met with administrators and DONs and discussed their role as essentially the CEO and chief operating officer of their facility. I met with CNAs and nurses and found how much and reinforced what 30 years in this field has shown me, which is most of these folks love what they do. I met with housekeeping and was always reminded of all the clinical nuggets that housekeepers can tell you about residents and their families. and met with residents who reminded me how much they appreciate the CNAs, the nurses, and the housekeepers. And this actually gave me some confidence and invigorated my view of the future. But I also learned a lot about the pressure that is felt in nursing homes in terms of budget and corporate pressures and things like that. Again, one of my favorite lines I hear from the administrator was, well, corporate told us to do this. And I said, wait a minute, I'm corporate. I never told you to do this. And so really began a journey into understanding how and why this happens. And I do like to share this, and it helps put this into focus. The New York Times likes to call me a critic of the nursing home industry. I tried pushing back on that. They won't change. What I'm a critic of is how the money flows and what we understand about how the money flows. And that's at the height of transparency. What I'm not a critic of, what I fully support, is the nursing home profession, which is everyone in the walls of a nursing home who are working to try to help the vulnerable older adults who live there. And I have the greatest feelings for those folks. To put transparency in perspective and to put all of this in perspective, I'd like you all to look at a nursing home and a nursing home chain as a three-sided scale. And the three sides of that scale are operations, finance, and clinical. And the goal of a nursing home administrator, the goal of a nursing home chain CEO should be to keep this scale balanced so that none of these areas is off balance with the others. So while you visualize that, I'm going to add in another challenge here. The folks who run nursing homes and nursing home chains have a fiduciary responsibility. They have a fiduciary responsibility to their board, to their shareholders. The folks who work for these facilities and companies have a fiduciary responsibility to their employers. Fiduciary responsibility is primarily financial in nature. I think we have to just accept that and own that. As clinicians, I took an oath in 1985, the Hippocratic Oath, and I have a moral and ethical responsibility. I've often said, what if nursing home CEOs had to take the Hippocratic Oath? Might that not change things a little bit? And it might, because honestly, our moral and ethical responsibility is primarily clinical in nature. So why is this important? And where am I going with this? Last year, a report came out on private equity. You'll read all sorts of things about is there how much private equity? Forget all that. This study was profound in demonstrating that where the private equity money is, you have greater mortality, you have greater spending, you have lower nursing staff. And one of the things I learned years ago on the business side of healthcare, everyone talks about lowering costs, but no one wants to lower costs, because when you lower costs, you lower revenue, you lower your net profit. So you could have a profit margin of 50% on a low revenue, or you could have a profit margin of 5% on a high revenue. What shareholders want is that higher net profit. And so really makes a lot of sense that there was a relationship between private equity and increased operating costs. So a lot of folks, when they think about private equity and transparency, they think about rent and real estate, myself included. That's been one of the things I've written and talked a lot about. I think most people stop when they look at real estate and they think, okay, whoever owns the real estate is just getting the rent. That is only the tip of the iceberg. And if you know anything about commercial real estate, you know that the person who owns the real estate, not only will they charge rent, but they'll charge what's called triple net. They get the operator to pay not only for the rent, but for real estate taxes, for insurance, for maintenance. So the owners of the real estate get to sit back, and the operators actually pay for all the things that allows their property to appreciate in value, which becomes the second item. The owners gain from appreciation. Ironically, these two areas are actually not the biggest ones as it relates to real estate. The biggest area is the leveraging of assets. So owners of nursing home real estate assets leverage that real estate to borrow more money. And that borrowing can be in the tens of millions or billions of dollars. And do they use the money they borrow to improve quality? Almost never. So there's a lot of money out there in the real estate of nursing homes that could be used to improve quality that isn't accessed. It's basically used generally to buy more real estate. And so we published a paper in Health Affairs in February of 2021, and a lot of what's in the National Academy report on recommendations includes from this paper the president's plan for nursing homes as it relates to transparency and accountability. Used a lot of what we put in here. And really the idea is without accountability and clear lines of responsibility, you cannot assure financial viability. And we have to address this. We have to address the drivers of profit. We have to recognize the role of real estate, related parties. And the reality is there may be enough money in the system already. It's just that we have to focus it more effectively. I think the last thing all of us would want to see is more money come into the system and that money being diverted to areas that don't improve the quality of care. And so with that, I'm going to make a few more comments that focus more on quality. And it's funny, Dr. Wagner mentioned Nicholas Castle. He's like my hero. About a decade ago, he published some really good studies on leadership in nursing homes. And one of those studies looked at consensus style leadership versus autocratic and shareholder manager leadership. And what you have to realize, and this brings me back to my summer of going to all these facilities, a lot of nursing home administrators will say, well, corporate tells me to do this. And a lot of nursing homes focus on what the shareholders want and what the bottom line wants. And really a minority of nursing homes function with a consensus style of leadership, which ironically, as Dr. Castle and others have shown, a consensus leadership style actually has been shown to be associated with significantly lower staff turnover, which everyone knows if you don't have turnover, you have fewer pressures to hire more staff. And number two, consensus style leadership has been associated with improved quality. A number of quality metrics have been shown to be positively associated with consensus style leadership, and just showing and higher quality metrics, higher inspection scores, etc. And I share this because when we switch over to the whole quality discussion, I'm trying to make the point that we have to focus on leadership if we're really ever going to get to quality. And so with that, I want to make one last comment that we wrote a white paper for CMS last summer where we made a number of recommendations that actually fit with a lot of these things. One of those that is presently been given to MITRE to get going is a pilot for resident family community and community advisory councils. And again, why would this matter? Well, when communities and families are given some voice and that voice is associated with accountability, and you combine that with transparency, we have a means for some pressure to actually make improvements. And two of my other favorite comments, and Joanne, someone alluded to this, I could listen to Joanne all day. We need subject matter experts, and those of us in the field of geriatrics and long-term care medicine have long been excluded from the policy making rooms. And then you get what you pay for. You've got folks who've never set foot in a nursing home making policy decisions that affect the care of nursing home residents. And so I think it's absolutely critical that the experts are included. And then finally, the importance of leadership is you can have all the policies and procedures and checklists, but without good leadership and consensus style leadership, that I think you're not going to make the progress that can be made. And that's it.
Great. Thank you so much, panel experts. We're now going to begin answering questions that were submitted during your presentation. And again, just as a final reminder, you can still submit questions through the questions pane in your attendee control panel, or if you're in the live classroom, just go ahead and raise your hand. We do have, which is something that's more like a comment actually, and I'll just read that out to you. I feel that change in regulations through funding for research projects to provide more evidence will take a decade. We need to lobby for change, knowing what we know now. And with that, Doctor, oh, go ahead, Doctor.
That's open to anyone on the panel.
So I have to tell you, similar on the subject matter expert stuff, we as a country, we've done a lousy job of doing research. Just imagine if Moderna and Pfizer had been required to include nursing homes in their original vaccine research. We would have probably got the vaccine out 2 months before we did, because the power of those findings would have been remarkable. There's just probably the single greatest example of how we have completely and utterly failed to require research in vulnerable older adults.
Yeah, and I would just say I agree with the point. However, there's just not enough research in nursing homes. There's very few of us out there, and the more that we can show data, to me, data illustrates a story that we can share with policymakers. And hopefully, it doesn't take 10 years, but sometimes it does.
I have a question.
Is there a question?
Yes.
Go ahead.
Thank you so much to the panelists for your excellent presentations. This is Tatiana Shippey, and I have a comment and a question, if you would. So my comment is that, and this could be especially for Dr. Sloan, maybe I am an optimist by nature, a glass half full type of person, and maybe coming from a different generation, because for me, the Nassim report was historic and inspiring. I think about the IOM 1986 report, and I wasn't doing research at that time. And so people from my cohort who have dedicated our careers to improving long-term care, it felt very reassuring and validating, even when a lot of it is repetition, and I agree with you on that, to see the statements on quality of life in the recommendation number 1. And for full disclosure, I am a co-lead of a committee that aims to implement that first recommendation. So I guess for general information, after this report was released, a lot of us have been asking how will these recommendations be pushed into practice. And so Hartford Foundation funded an initiative called Moving Forward Nursing Home Coalition. Some of the folks who were in the initial report, like Dr. Jasmine Travers, Dr. David Grabowski, are part of this effort. And the effort has assembled 7 committees to address each of the 7 recommendations. And I have an honor of co-leading committee number 1 with the leaders of the Pioneer Network and the Greenhouse Coalition to get at those culture change efforts. So I'm maybe a little bit biased, Dr. Sloan, but I feel like this is prime time for us to center on person-centered quality, equity, culture change, quality of life, all the things that we know matter, all the things that the Keynes, my mentors at the University of Minnesota have called for in the early 80s. But change sometimes takes time, so maybe it's incremental. So this is my comment. If you're interested in this work, please check out Moving Forward Nursing Home Coalition. We're soliciting, now building more committees, but also hoping to move it into practice. And we definitely have geriatricians on the committee. But my question to all of you is, what do you all see as the low-hanging fruit from this report? So much work from all of you, other panelists, technical experts, everybody who participated in this 600-page report. So much work, energy, passion, and commitment went into it. What do you see as some recommendations that could be sort of implemented short-term versus long-term? Thank you.
That is a tough one because we all would like to see the higher hanging fruit get approached. To me, the biggest barrier is dealing with finances, and I really appreciate hearing the optimism, you know, and love people working on it, and I'd love to see change. You know, I've just been working in the field, you know, so long, and for me, I've seen a number of places that are good, but for me, the real indicator is would I like to live there? Would I like to be there? And is the there a ordinary community nursing home as opposed to one that's in the CCRC, the kinds of ones that many of the people in this panel tend to be affiliated with? I'm talking the National Academies panel. You know, I've been in a lot of nursing homes in North Carolina over 40 years, and if you go into the average ordinary nursing home, it's not very different than it was 30, 40 years ago. And that's, the question of what would make that happen. And then I was a PACE doctor. I worked in PACE for 5, 6 years, and I loved it, and the people were happy. And can we make that happen? Is the population so different, so impaired? Are the burden of care so difficult? I don't know if there's a low-hanging fruit, to tell you the truth. When the goal is, would you like to live there?
I would agree with Philip that it's not the low-hanging fruit, it's the high-hanging fruit. And to me, there's 3 things. The first is transparency. I think without transparency, we are going to struggle mightily to address the financing. And I think there's some very clear direction on transparency to be out there. By the way, for full transparency, I'm on the transparency work group for moving forward. So number 2 is staffing. And I know we all don't like to be told you need X amount of this or X amount of that, but we also are well aware from the literature that far too many nursing homes around the country just don't have enough staff. And so I think the staffing recommendations, I think, will be a great opportunity to coincide with the efforts CMS is now taking. And I believe will also provide some positive pressure on CMS to get that right. I mean, then the third thing is I've really become a fan. I say Dr. Castle's work a decade ago, which I only discovered in the last year, has just profoundly changed my view, because we have evidence-based literature on leadership, and it's time to act on that evidence-based literature to promote it. And then the last thing I will point out that will be a challenge for moving forward, and as you're on one of the co-chairs, is if we just come up with more recommendations upon recommendations, we're going to be sitting here another 20 years from now, as Joanna said. And I think one of the things that I'm trying to encourage from the folks leading that effort is what Joanne also talked about. If those recommendations are not made with an eye towards the White House, Congress, CMS, and how to actually work effectively within the existing political system and structure to get them implemented, we will still be looking at them 10 years from now.
I'm going to ask, this is Paul, I'm going to ask a follow-up question. One of the one of the things that emerged from OBRA 87 and the nursing home reforms was a much more robust regulatory framework. And so now we fast forward to 2022, as Phil said, similar sort of recommendations as 1986, but are we still going to rely on this, what many people describe as an onerous regulatory framework that stifles creativity, makes people paranoid on the front lines? Mike, your thing about, the corporate told me to do this, well, or CMS tells me to do it, I can't do anything else. I'm just afraid that with that framework, it's going to be very difficult to implement any change you're talking about.
Well, we do have a model for this in with the Joint Commission. I've done some work on voluntary accreditation in nursing homes, and you can get hospitals can get a waiver from CNS by being Joint Commission accredited. We don't have that same structure for nursing homes, so yes, the regulations do stifle creativity, but there may be other ways that we can accredit, if you will, nursing facilities through voluntary accreditation, and it might be more empowering to them to be involved in that.
Interesting. Our research group is studying accreditation of assisted living, that the state of North Carolina asked us to do, and they would love to see if they can use that as a method to assure quality rather than having people go around once a year. And
Yep.
Yeah, I've long been a fan. I actually was a public commissioner on the Continuing Care Accreditation Commission a couple decades ago, and do agree. At the same time, we published a paper, Arif Nazir and a group of us with AMDA published a paper on upgrading the survey process. And last year, I do believe that paper provided a really nice framework for the efforts that we must take. And I do agree, to ignore the survey piece is not wise, because it does, for all of us who work in nursing homes and have worked in nursing homes, we know firsthand the morale impact of this existing process. And look, it's well intentioned, but it absolutely must be improved.
You know, the survey process is an external process, and the accreditation process is an internal process. That makes a big difference. And the other thing about the survey process that makes it difficult is surveyors aren't paid very well. You know, they're not necessarily the most go-getter, you know, informed, you know, folks. And so some other model is going to be helpful if it works. Lori, you have thoughts about this?
Well, yeah, another approach that we provided in that research that I did was looking at just how do we prioritize our time, instead of every facility getting a 3-day visit, or whatever it is like maybe the better performing facilities get a visit every couple of years, where we have lower performing facilities having more contact, so that maybe reallocation of the resources on whether it be an inspection or an accreditation, however that looks. That might be it might be a better use of our time.
You know, the other
go ahead.
I would say sort of an improving upon the present QAPI. And one of our recommendations on our white paper was it shouldn't be called quality assurance performance improvement, but quality assessment performance improvement. And that goes to your point, Phil, that the real QAPI, a good QAPI, which is rarely done, really is internal, involves all the staff, involves the ombudsman, involves the CNAs. It's a true team effort. There's a lot of opportunities to build on the idea of QAPI rather than what actually QAPI has turned out to be. So I think QAPI is a very good angle towards all this. It really needs to be utilized.
Yeah, thank you. It's a carrot and stick debate as usual, and I wish there'd be more carrot. And really, and I think Mike, you were referring to this, more of a quality, a QI framework when the surveyors come in and find a problem, rather than penalize you, give you an approach and an ability to resolve that problem creatively rather than being punished. So. Claire, are there other online questions?
I don't have any more questions, but I believe Dr. Lin had a comment she wanted to say. So go ahead, Dr. Lin.
I mean, we've been talking a lot about the National Academy report on nursing homes. They completely bowed out on the financing. They recommended 2 elements in the financing, both of which are inane. One was that we should do more research on the financing issue. And sure, we should update things because our research is 5 or 6 years old. But basically, we have enough research to know what the calamity is we face and how to solve it. And they recommended that the states do social insurance so we could learn about it. Well, we've already learned from Washington State that that's an inane idea. And it was the only piece of the National Academy report that was not endorsed by all parties. I don't know who was a holdout and whether the holdout was because the 2 recommendations were inane, or whether the holdout was because the person didn't even agree that we should be concerned about financing. But that was followed by a National Academy report on, quote, healthy longevity, unquote, which reads like a novel that failed to put in its last chapter. Has wonderful chapters on all the pieces, on housing and on food and on disability support and on measuring quality and all sorts of good things, and never talks about how we're going to die. And we are going to die with substantial disability. And that was never in the report. The only time they mentioned mortality was in a critique of using mortality figures as a quality measure. So we're beginning to see some progress with the American College of Physicians report, which was at least honest. But if we can't get people to talk honestly about what we face, we are really going to be in deep trouble. Can you imagine in just 10 years from now, while most of us on this call are still going to be alive, having half of the middle class unable to afford housing, food, and medical care? We are going to have huge numbers of people homeless in their 80s and 90s. Where's the anxiety over this? Paul asked if I could sleep at night. Maybe I shouldn't be able to. Maybe none of us should be able to. I mean, if we are not tackling the fundamental problems, the organization of care and the payment for it, everything else is icing on the cake. We are going to fail in taking care of long-term care. We're going to have lots of medical aid in dying so that people can kill themselves rather than face our long-term care system.
So,
If that's the future we want, there we go.
So Joanne, I'm going to double down on something you already called out for everyone to do. Everyone on this meeting, in this meeting, should go home, or if you're home already, go online, look up, see who your state assembly person, your state senator is, see whose congressional district you live in, and reach out, especially to your congressperson, your senator in your state, to their healthcare staff, and make that connection. And I think this is something we have failed mightily as a field in doing. And I spoke to a colleague the other day who actually has a great relationship with a United States senator. And I said, do you know his healthcare staff? And he said, no. And I said, there's the problem, because it's the staff who does the work. You can be best friends with a US senator and tell them what you think, but unless their staff's in the room and involved, nothing's actually going to happen. On the other hand, if that staffer knows that you're friends with that senator or congressperson, they're going to listen to you. And we have not used this path. And I think we have to put our foot on the accelerator, encourage all AMDA members, all American Geriatric Society members, all Gerontologic Society, Geriatric Farm, ASCAP, everyone, to do what you actually asked us to do, Joanne. So I just go back 30 years, and I have always felt, just listen to what Joanne says, and we'll be okay. We just got to get more people to listen to you, Joanne.
I think if there are no other questions, that might be a good part to end our conference. So I want to thank the panel, Dr. Lynn, and all of our presenters this morning for just a fabulous day. On behalf of Dr. Granville and I, who represent the North and Central Florida GWEP and our NOVA partners, thank you again for the great accommodations today. All attendees will receive a follow-up email within a day that will include a link to the conference evaluation survey, which we really do appreciate. And for those who paid for continuing education credits, the survey will also request some documentation for CE reporting purposes. All of the PowerPoint presentations, as well as a recording of the webinar, will be posted either on the FSU College of Medicine's REACH website and the Nova Southeastern University's SF GWEP's main webpage, as well as YouTube channel. You know what, Clara? I think I just read your lines. So I saved you a few minutes. If I had been there for practice, I wouldn't have done that. I apologize. I do want to thank Clara and GoToWebinars for a fabulous day. And no glitches. I also want to thank, I know, the IT department at NOVA really went out of their way to help make this happen. And thank the audience here for all of your participation. And we look forward to next year. We don't know exactly where we'll be. Maybe we'll be here. I don't know. But again, thank you for a wonderful day.